Good evening, everyone. It's with great pleasure I invite you all to attend the third Best Clinical Oncology Symposium 2022. I invite Dr. Naresh Somani, sir, the program director of this great endeavor. Over to you, sir, for the introduction of this program.
So, without taking much of the time, I would like to invite Dr. Lalit Sharma, who will be taking care of today's program. I would like to say a few words only that this oncology symposium came in our mind. Rather, it was the need of the hour when the COVID pandemic started, the first wave started in India. A lot of new things were coming. We were treating the patients, but we were not able to get connected with everyone, but not able to getting updatation, everything. So this is how the best clinical oncology or the BCOS started. And with the, I will say in the lighter vein, that with the every passing COVID wave or the new wave, we keep moving. And here, today here we are with you in the third best clinical oncology symposium. So I wish that the COVID goes, but the BCOS remains with the fourth edition and subsequent editions. With all your support and with your best wishes, we will be doing it. And good thing about this is that we kept rotating the organizing persons, organizing team. Initially, it started from the Jaipur, but being the webinar, it was easier for us to include everywhere. And I would like to acknowledge, congratulate, and would like to say thanks to both organizing secretaries, Dr. J.B. Sharma as well as Dr. Tejendra Singh, that they came forward and they accepted this responsibility and did a lot of efforts to make it a successful and to go through this program. So with these words, I would like to invite Dr. Lalit Sharma, medical oncologist from Mahatma Gandhi Hospital, who is good friend of mine, who is well-known figure in the field of the medical oncology, very enthusiastic persons as far as the academics, meetings, clinical research, and the another dimension which has been added in the personality or the feature of Dr. Lalit Sharma is that he has learned formally the preventive oncology also, and he's doing lot of now activities to cut down the tobacco consumption, to reduce the various ecological factors regarding the cancerogenesis in the Rajasthan all state, and lot of activities he is doing in that field also, apart from his the core oncology practice that is in the form of the medical oncology, pediatric oncology, and hemato-oncology. With these few words, which is small words only for the dimensions of Dr. Lalit Sharma, I would like to invite Dr. Lalit Sharma to start the proceedings. Dr. Lalit, please. Is Dr. Lalit available?
So I believe there is a slight confusion. I am Dr. Lalit Sharma from Manipal Hospital.
Oh. So, okay. Doesn't matter. So let me introduce Lalit again. So we have the two Lalits in Jaipur now for everyone's information. And both are at the different corners of the expanding city of the Jaipur. Dr. Lalit Sharma, who will be taking care of this webinar today as coordinator, is medical oncologist at the famous Manipal Hospital. He is again well-known figure in the medical oncology and doing a good job. He is also in the academic and the clinical research and the practice. And he is a young budding medical oncologist with lot of futures I see in him. With these few words, I would like to invite Dr. Lalit Sharma to start today's proceedings. Dr. Lalit, please.
Thank you so much for that welcome, sir. So I would like to invite all the dignitaries for this yet another day of a sumptuous academic feast. And to start with, I would like to invite Dr. Manish Kumar to give the welcome and introductory note. Dr. Manish Kumar is consultant medical oncologist at American Oncology Institute, Gurugram. Over to Dr. Manish Kumar. Dr. Manish Kumar, are you able to hear me? Okay, so I would like to invite Dr. Pawan Agrawal as a chairperson for this session. Dr. Pawan Agrawal needs no introduction. He's a senior consultant medical oncologist at BMCHRC Jaipur, and he would be presiding over the proceedings in this particular session. So for the next talk, I would like to invite Dr. Satvik Khattar. Dr. Satvik Khattar is consultant medical oncologist at SRJ CBCC Indore, and he would be delivering a talk on association of plasma tumor tissue modified viral HPV DNA with tumor burden, treatment type, and outcome. Over to Dr. Satvik Khattar.
Thank you, sir. And thank you all the esteemed faculty for giving me this opportunity. I would request the organizers to allow me to share the screen. Yeah. I hope the screen is visible in I hope the screen is visible, so I'll start my presentation without any delay.
Yeah, it's visible.
Yeah, thank you. So today's topic is association of plasma tumor tissue modified viral HPV DNA, that is abbreviated as TTMV, with tumor burden, treatment type, and outcomes. This was a translational analysis from NRG HN002 trial, and this was presented in this ASCO this year. So a little bit of background. This trial started in October 2014 and was closed in July 2017. This was a phase 2 randomized trial for low to no smoking patients with P16 positivity of oropharyngeal cancer. And the randomization was between CT-RT versus accelerated IMRT at 60 gray. So this is the trial design: oropharyngeal cancers with low or no pacquiao history, T1, T2 node positive or T3, N0 to N2B disease, and with a centrally reviewed P16 positivity, which was required. And they were randomized between CT-RT with the cisplatin and versus only IMRT accelerated for 5 weeks. And the co-primary endpoints were 2-year progression-free survival and 1-year MDA-DI, that is MD Anderson dysphagia inventory. So the protocol specified plasma collection. The plasma collection for the HPV viral load was done at 3 time points. T0 was the baseline before starting of the treatment. Then T1 was intra-treatment when 20 to 28 gray fractions RT was given. And the last was end of treatment, that is T2, which was from 2 weeks to 1 month after completion of treatment. So circulating tumor tissue modified viral HPV DNA was detected from blood, and it consists of cell-free DNA with plus viral DNA, which constitutes the TTMV HPV DNA. And it was quantified as fragments per ml of plasma, and they defined undetectability as less than 5 fragments per ml. And if the HPV 16 was below the range of detectability, then it was tested for other HPV virus like HPV 18, 31, 33, or 35. So they had 3 major pre-specified hypotheses. First was pre-treatment hypothesis, which suggested, which they hypothesized that a higher TTMV at baseline is correlated with a higher GTV of primary and lymph nodes. That is a higher T stage and a higher N stage. And the second hypothesis was intra-treatment, that TTMV decreases from baseline to as the treatment progresses, that is in intra-treatment evaluation. And the third hypothesis was post-treatment, that is TTMV detectability at T2, that is post-treatment, reflects response to therapy, with patients achieving undetectability, having a lower 2-year locoregional failure and a higher 2-year progression-free survival. So this is the statistical analysis, and the data were log transformed, and paired t-test was used for intra-treatment, and between group comparison was made as a 2-sample t-test. Post-treatment Fisher's exact test was used to compare treatment arms, and negative predictive value was estimated with 95% confidence intervals and 2-sided alpha of 0.05. So this is the demographic of the patients. Close to 50% had cisplatin as the concurrent chemotherapy. Majority were males. 81% were performance status 0. 70% were non-smokers, and tonsil was primary site in close to half of the patients. So this is the feasibility of the plasma sample collection. 53.6% patients donated at least one specimen, and patient participation rate, as you can see at baseline, it was 53.6%, which decreased slightly as the treatment progressed. And these are the results. Plasma sample collection at baseline. As you can see, 10% patients had undetectable TTMV even at baseline, and majority had HPV-16 positivity. That 78% had HPV-16 positivity, and those who did not have HPV-16 positivity among the patients who were positive, rest were 18, 33, and 35 were in close to 1 to 3% of patients. So coming on to the results, hypothesis 1, which was the baseline TTMV correlated with a higher T and N stage, as you can see in the graph as well as in this chart, it was statistically significant that a higher T stage correlated with a higher baseline HPV viral load, as well as higher N stage also was statistically significant that a higher viral load correlated with a higher N stage. Coming on to the hypothesis 2, that the TTMV load decreases as the treatment progresses, and it was seen that the TTMV value decreased both in the CTRT as well as only IMRT arm, and they also have shown that the decrement in the TTMV value was more in the CTRT arm as compared to accelerated RT alone arm, and which was also statistically significant with a p-value of 0.03. As you can see, so IMRT plus cisplatin resulted in more decrement of the TTMV viral load. Coming on to the hypothesis 3, that is the post-treatment sample. So the T2, that is the end of treatment detectability rate, was 3.3% for IMRT-C arm, that is CTRT arm, versus 8.7 for IMRT arm. However, this was statistically not significant. Coming on to the negative predictive value. So a negative predictive value for 2-year local regional failure with TTMV negative was 95%, and for 2-year progression-free survival was 93.3%. So TTMV negativity at the end of treatment has a very high negative predictive value, as you can see here also, and probability of having an event was local regional failure event, that is detectability, was although statistically not significant, but detectability at end of treatment was correlated with a lower progression-free survival as compared to a negative TTMV status at the end of treatment. So coming on to the conclusions, so this trial basically showed the feasibility of plasma collection and secondary assay of TTMV HPV DNA in clinical trial specimens. Close to 10% of P16 positive patients had zero detectable TTMV fragments at baseline, and among those with clearly detectable TTMV, 6% had types other than the HPV16. And as I have shown, T and N stage were weakly to moderately associated with higher baseline TTMV fragment values. CTRT arm achieved a more rapid decline in TTMV by 2 weeks of CTRT compared with IMRT alone. And the negative predictive value of post-treatment undetectability was 93 to 95% for 2-year local regional failure and progression-free survival, and clear detectability was associated with a PFS event, which was statistically significant. Thank you.
Thank you so much, Dr. Satvik, for that wonderful presentation. So shall we take the questions right now or at the end of the session? Okay, because I do not see any questions in the chat box, let's take the questions at the end of the session. For the next talk, may I invite Dr. Sarthak Tandon. Dr. Sarthak Tandon is a consultant radiation oncologist at RGCI Delhi. He'll be talking about radiotherapy alone versus concurrent chemoradiotherapy in intermediate risk nasopharyngeal carcinoma. Over to Dr. Sarthak Tandon.
I hope I'm audible.
Yeah, you are audible, sir.
Good evening, everyone. And just before starting, at the outset, I would like to thank the organizer for giving me this opportunity of presenting my this ASCO publication, this ASCO abstract. So without any further ado, I just would want to start with the presentation. And so I'm basically presenting this oral abstract presentation on radiotherapy alone versus concurrent chemoradiotherapy in intermediate risk nasopharyngeal carcinoma. So it was a multi-center, open-label, a non-inferiority randomized phase 3 trial, which was basically addressing the dilemma of how to manage the intermediate risk nasopharyngeal cancers, basically the T2N0s and T1, T2, N1, and T3, N0s. So before we jump to the abstract, what are the basic earlier evidences? We all know, I'm not going to repeat into going into the Al-Sarraf trial or probably the V et al. And all the articles which were present. So they basically established the role of concurrent chemoradiotherapy followed by an adjuvant PF. So to add adjuvant chemotherapy on a backbone of chemo-RT. But a lot of has changed, and the rationale behind is that in the pre-IMRT era, the primary failure were loco-regional, and concurrent chemotherapy were added at radiosensitizing doses to trying to increase the loco-regional control rates. However, after the IMRT era, there are a lot of evidences which have shown that by adding this, we have a survival advantage, and the loco-region control rates have increased. The primary failure, the failure is now shifting towards distant failures. So the question remains is that what about the intermediate risk? Do we need to visit our evidences again and probably check on what is the rationale and logic behind adding concurrent chemotherapy in the intermediate low risk setting of nasopharyngeal? So these participating institutes of the abstract that I'm presenting, they initially started with meta-analysis of retrospective series and phase 2 trials. So this was one of the first meta-analysis that they had published, and they basically showed that out of the 2,138 patients that they'd used in their systematic reviews, addition of chemotherapy to IMRT in stage 2 nasopharyngeal cancer did not improve either overall survival or the loco-regional failure survival. Neither did this meta-analysis, which was published in 2018. They again tried to assess the importance of addition of chemotherapy to IMRT. Now, I want to reiterate that all these trials are using IMRT and not the 2D era data. So the meta-analysis showed that the OS and PFS did not improve when you add chemotherapy specifically to stage 2 nasopharyngeal carcinomas. This is a similar another meta-analysis which again showed similar findings that addition of chemotherapy did not improve survival data. So these the authors of the abstract, they had also published a phase 2 study before initiating a phase 3 study, and the phase 2 data showed, which included about 84 patients and had included about patients from 2010 to 12, and they showed that again addition of chemotherapy to IMRT specifically in stage 2 nasopharyngeal cancer did not improve any of the survival outcomes, be it in terms of overall PFS, loco-regional, or distant control rates. So coming back to the ASCO publication, the exact oral abstract presentation, it was a non-inferiority trial initiated in 2015, ended in 2019, and had a cutoff analysis point at 3 years. So what was the basic inclusion criteria? They wanted to take non-keratinizing type, the endemic type of nasopharyngeal cancers, and included stage T1, T2, N1, T2 to T3, N0 stage, basically stage 2 and T3, N0. What is important is that we need to understand that they did not include any of the high-risk factors and had excluded those patients who had either extracapsular spread or bulky nodes or nodes which were below level 4 or 5, and a pre-treatment plasma EBV DNA levels of more than 4,000 copies. Again, suggesting that these were high-risk patients which were excluded. They included, so it was a non-inferiority trial, so they set the non-inferiority margin and wanted to assess the failure-free survival. So the failure-free survival was taken from the date of randomization to the date of treatment failure or death from any cause, whichever is first. And for assessing secondary endpoints, they included 4 parameters, the survival outcomes in terms of OS, the loco-regional failure-free survival, distant failure-free survival, and rates of the adverse events. They wanted to assess acute and late toxicities, acute being during the treatment and late at 3 years. So the trial schema was they divided the patients into two arms. One was with concurrent chemoradiation arm, included IMRT to a standard dosing pattern with cisplatin. And they added chemotherapy, cisplatin concurrently, 3 weekly at a dose of 100 milligram per meter square, along with in fact, the experimental arm was the radiation alone arm, which had IMRT to the same exact setting as in that of the comparator arm. And the patients were 169 vis-a-vis 172. So at a median follow-up of 41 months, you need to understand that this was a non-inferiority trial, and the FFS, or the failure-free survival, did not breach the barrier of inferiority margin, and thereby suggesting that radiation alone was non-inferior in terms of primary outcome when compared to the comparator arm, which was chemoradiation arm. So the ITT, the intention to treat analysis, showed that 3-year FFS was 92 versus 90 in CCRT versus RT. And the per protocol was 3-year FFS of 92.1 versus 90.7. When you look at the secondary outcome measures, they showed that none of the parameters in terms of 3-year OS, distant metastasis-free survival, or loco-regional recurrence-free survival, either when you analyze by ITT or by per protocol population, they showed any difference in comparison to RT or CCRT. So both their primary and secondary outcomes in terms of survival measures showed equivalence, or probably a better word would be a non-inferiority measure. The secondary outcome measure in terms of toxicity, when you compare CRT versus RT, it was obvious and intuitive that there were higher toxicities in the chemoradiation arm. There were higher vomiting, anorexia, mucositis, and weight loss. However, they did not report any grade 5 toxicities in either of the arms. So what do the guidelines say? The guidelines are very ambiguous in answering the particular question, and probably that is the reason that we needed a phase 3 trial for this question. The ASCO is more liberal, is more stringent in giving chemotherapy in these settings, whereas NCCN is the most liberal of the guidelines, and ESMO is somewhere in the middle. So what do we come out of this? I mean, we have to wait for the entire article or the published data to assess what are the pros and cons of this phase 3 trial. But till then, I think what has been established till now is that nasopharynx, we need to understand that IMRT is the standard of care. And IMRT CCT is the standard backbone for management of locally advanced. There's no doubt about it. And the use of neoadjuvant adjuvant is something that the question needs to be answered in further trials. And the intensification of treatment using EBV titers is something which is also undergoing in our a lot of data. T2N0 is one subset where there is maximum number of consensus regarding there is higher level of evidence of skipping concurrent chemotherapy vis-a-vis T2N1 and T3N0, where given this is a single trial, omitting chemotherapy should not be the criteria and probably can only be done on a trial basis. Whereas T1N1, I think we can do a risk adaptation in terms of if there are any high risk factors, you add chemotherapy. And if there aren't any, I mean, again, it is a decision based on your the institutional practice. But this is the basic crux of the intermediate nasopharyngeal cancers. Thank you.
Thank you so much, Dr. Sarthak, for that wonderful presentation. And going ahead with the next session. The next session is sponsored by Biocon. And for the next talk, I would like to invite none other than Dr. Govind Babu. Dr. Govind Babu sir needs no introduction. He is the renowned consultant medical oncologist at St. John's Medical College and Hospital and HCG Hospitals, Bangalore. And he'll be delivering his talk on nimotuzumab plus chemoradiotherapy versus placebo plus chemoradiotherapy in patients with locally advanced nasopharyngeal carcinoma. Over to Dr. Govind sir.
Thank you, Dr. Lalit, for that introduction. And let me again thank the organizers and Dr. Naresh for asking me to be here and present this topic for you. So as you heard, this paper was presented at the recent ASCO, And this is titled as Nimetuzumab plus chemoradiotherapy versus placebo plus chemoradiotherapy in patients with locally advanced nasopharyngeal carcinoma. So my acknowledgements are to Professor Jansun and the trial team for allowing me to borrow the slides. So this is a prospective randomized controlled double-blinded multicentric phase 3 trial. So the background of the study is, I think you heard a little bit about how nasopharyngeal carcinomas are treated, and the newer concept of looking at the viral load is coming up in a big way. So for this study, it was that concomitant chemoradiotherapy increases survival in patients with locally advanced nasopharyngeal carcinoma, and adding nimetuzumab to radiotherapy improved clinical efficacy in a phase 2 study of nasopharyngeal carcinomas. And this paper was presented about 4 years ago again at ASCO. And it was unknown at this point of time if combination of nimetuzumab plus concurrent chemoradiotherapy would provide survival benefit. So that's a background of designing the study. So this is just to tell you what nimetuzumab is, and it's marketed in India as Biomab. This is a humanized monoclonal antibody, which means that more than 95% of this monoclonal antibody has human sequences. That leads to negligible hypersensitivity reaction as compared to the other molecules in this category that block the EGFR pathway. And also it can, therefore, the humanized 7-domain confers the safety advantage. So that is about nimetuzumab. And we already have enough data on the safety and efficacy of this molecule in the Indian population. The first one was this study called BEST, which was done way back in 2014, and I happened to be a part of the study. And just to show you that adding nimetuzumab plus with chemotherapy, chemoradiotherapy in, of course, this is all squamous cell carcinomas of head and neck region, that everybody had a response at the first assessment. And then we had this Tata study, which is a phase 3 trial, which is presented at ASCO again a couple of years ago. And this actually showed that nimetuzumab with concurrent chemoradiotherapy improves PFS, distant disease-free survival, and overall survival as well. So we know that nimetuzumab is a molecule that we are all comfortable with using. So this coming to this study, this was, as I mentioned, it was in nasopharyngeal carcinomas, locally advanced stage 3A and 4. This is the staging of the China version, as the study was done in China. And the primary tumor should be measurable, KPS more than 70 points. And the randomization was 3:1. And 362 patients were in the arm A that got nimetuzumab at 200 milligrams weekly for 78 weeks. Chemotherapy consisted of cisplatin 100 milligrams per meter square Q3 weekly, and the standard radiotherapy. Whereas the other arm had placebo, chemotherapy, and radiotherapy. And the primary endpoint was a 5-year overall survival. Actually, I'm very impressed by this primary endpoint because they actually looked at survival with a follow-up of 5 years. And the secondary endpoint include overall response rates, disease control rate, and disease-free survival. So this is again how these patients were in the study. 361 were randomized into the study arm. 53 discontinued due to various reasons. The number that completed were 304, and as you can see, the follow-up is here. In the placebo with concurrent chemoradiotherapy, 121 patients were enrolled. Again here, a similar number of 53 discontinued and 108 completed therapy. So this is the basic demographics and clinical characteristics. Just to tell you that both the arms, they were pretty well matched with no significant difference. Now this is the 5-year overall survival. As you can see here, that the median overall survival for the patients who got nimetuzumab, that is in the green arm, is shown here, was 76.9%, whereas for the arm that got placebo, it was 64.3%, with a hazard ratio of 0.64. And they concluded that addition of nimetuzumab to concurrent chemoradiotherapy provided a 12.6% absolute survival benefit at 5 years. So this is 5 years overall survival per protocol segment. And again, as you can see here, the difference was nearly 10.5%, 74.7% for nimetuzumab arm and 64.3% for the placebo arm. So per protocol analysis showed a non-significant improvement in 5-year overall survival, not a significant p-value, but the difference is about 10% here. So subgroup analysis of the 5-year survival. So they looked at a number of patients, the fractions of radiotherapy that they got. They looked at those who got more than 25 or less than 25, and chemotherapy, number of chemotherapy cycles more than 2 or less than 2, and age more than 65, less than 65, and tumor stage 3 or 4. And as you can see here, those patients who got less than 2 cycles of chemotherapy are doing slightly worse as compared to those who got at least 2 cycles of chemotherapy. And this we have seen in the past as well, that those patients who get at least 200 milligrams of cisplatin per meter square are the ones that are going to benefit with the addition of chemotherapy to radiotherapy. So that is again, this study undermines that statement. Whereas all the others, you can see that every subgroup had an advantage when nimetuzumab was added with chemoradiotherapy. So coming to the disease-free survival, this is a full analysis. And as you can see here, the 3-year rate was 65.1% for the arm that got nimetuzumab and 60.3% for the arm that got placebo. So there was a non-significant difference at 3 years DFS, but favoring the nimetuzumab arm. And these are the standard definitions for DFS. So the best of response at 1 to 6 months is shown here. This is for the nimetuzumab arm, and this is for the placebo arm. As you can see that there were a larger proportion of patients in those who got nimetuzumab arm who had CR. Again, you must remember that the size of the bar is, as you remember, the randomization is 3:1, and therefore the difference in the size of the bars. But nonetheless, the arm that got nimetuzumab in terms of either CR, PR, or stable disease were definitely better. Of course, we did have a small proportion in both the arms where the evaluation was not possible for various reasons. So looking at loco-regional failure survival, at 3 years or 5 years, there was not significant difference between the two arms. The p-value was more than 0.05, but there is a numerical difference that exists. So at 5 years, 3 years and 5 years, it's still not reached a statistical significance. So distant metastasis-free survival. What we have observed by using these monoclonal antibodies is, most of the time these head and neck cancers, including nasopharyngeal, the disease used to come up in the loco-regional areas. But with the use of targeted therapies and immunotherapies, we are seeing a slight change in the sort of life cycle of these diseases, and we are seeing more distant metastasis as compared to just loco-regional failures. So this is an important endpoint that this study also looked at. And as you can see here, the distance metastasis-free rate at 3 years or 5 years was no difference in the two arms, more than 0.5, but there was a numerical difference. And probably with longer follow-up, we will see some evidence that adding nimetuzumab definitely is decreasing the distance metastasis. They also looked at the radiotherapy and the analysis for overall survival. This is looking at IMRT versus conventional radiotherapy, and they did find that there was slight difference when IMRT was used as against conventional radiotherapy. This is again shown here in terms of the complete response rates and overall survival, that there was a slight difference when the IMRT was used as compared to conventional radiotherapy. So looking at the safety profile, as I mentioned, most of us in India have been using nimetuzumab for more than a decade now, and we are well versed with the low toxicity that's seen with nimetuzumab. So, but adding this to chemotherapy with radiotherapy in this study did not increase the number of adverse events which are clinically significant in a large way, by which I mean grade 3 and 4, 17.7% for nimotuzumab and 15.5% for the placebo arm. Of course, if you see the grade 1 and 2, again, they're very, very similar. In fact, there is numerically slightly more in the placebo arm. So adding nimotuzumab in no way increases the side effect profile of the combination. So these are the common adverse events. We know that chemotherapy does produce hematologic toxicity, and adding nimotuzumab in no way increases the toxicity of chemotherapy. So to conclude, nimotuzumab combined with chemoradiotherapy in the treatment of locally advanced nasopharyngeal carcinoma has better efficacy. 5-year overall survival rate increased by 12.3%, 6%, with 36% risk reduction, and the complete response increased by 13.3%. And this combination had good safety profile. So with that, I think I will stop, and thank you very much.
Thank you so much, sir. Thank you so much for that presentation. Moving on, I would like to invite Dr. Vijay Patil, sir, for the next talk. Dr. Vijay Patil is a professor of medical oncology at Tata Memorial Center, Mumbai, and he'll be delivering a talk on low-dose immunotherapy in squamous cell carcinoma of head and neck. Over to Dr. Vijay Patil, sir.
I hope I'm audible and my slides are visible.
Yes, sir, you are audible and
so,
slides are visible.
Yeah, so we will be presenting the results of a phase 3 study, which we presented at ASCO, in which we validated the role of addition of low-dose nivolumab to palliative chemotherapy in head and neck cancer. Now, the idea for doing low-dose came because access to cetuximab and checkpoint inhibitors in our hospital is below 5%. In fact, one of our students, Dr. Ravi, presented a 15,000 plus data as an ASCO oral this year, which showed that the access to immunotherapy checkpoint inhibitors was 2.8%. And on the general side of head and neck cancer, it was 0.3%, that is even less than 0.5%. Now, even access to intravenous chemotherapy was difficult a decade back, and that was the time when, with the help of Dr. Banauli and Dr. Kumar Prabhash's guidance, we developed oral metronomic chemotherapy. It actually showed that it had a better OS than IV cisplatin, led to minimal side effects, and was oral, so was most preferred by most of our patients. We actually made the next generation of metronomic by addition of erlotinib and redefining the role of methotrexate, what we call as triple metronomic chemotherapy. This triple metronomic chemotherapy in platinum refractory setting gives a response rate of around 43%. And just to put this in perspective, nivolumab or pembrolizumab in the same setting give a response rate of less than 15%. So it does give immediate response to most of the patients. But the problem was the responses to triple metronomic were short-lived. And even though the median OS was similar to what we get with intravenous immunotherapy drugs in the platinum refractory setting, subsequent overall survivals seemed to be inferior than what we got with full dose. So the question was, how could we make this response more sustainable? At that time, there was a pharmacokinetic study which was done in Tata, and also we did a literature review. Now, nivolumab, the action of nivolumab is on the PD-1 receptor. For the nivolumab to act, 70 to 75% of the PD-1 receptors need to be blocked. The interesting thing is that 70% of receptor occupancy is achieved at a dose of 0.3 milligram per kg itself. And multiple retrospective analysis, one from Seoul, one from Russia, and in head and neck cancer from our group, had hinted that probably giving this drug in low doses might be beneficial to the patients. There was interesting rationale here also that one of the resistance mechanism to intravenous IO, that is checkpoint inhibitors, which is speculated as development of angiogenesis or more expression of receptor tyrosine kinase pathways. Now, triple metronomic seemed to be an ideal candidate because of the metronomic activity. We had an anti-angiogenic action. Because of presence of erlotinib, we had a receptor tyrosine kinase inhibitor also present. So it was like a 3-point where nivolumab would help to increase or sustain the responses which are achieved by metronomic. And the metronomic itself would actually inhibit the resistance which would likely to be developing to IO. And with this logic, we actually did the study, and the primary endpoint for the study was overall survival. We wanted to see whether addition of this nivolumab to metronomic chemotherapy in low doses improved survival. It was a pretty simple trial scheme, a phase 3 study, parallel design, 1:1 randomization, which was stratified according to the site of the tumor, oral versus non-oral, whether the patient had received previous treatment or not, and the time to failure, which was whether it was failed within 6 months, 6 to 12 months, or more than 12 months. Patients who were enrolled upfront were actually put in the cohort of which was greater than 12 months. Palliative chemotherapy, which we use in this setting, was triple metronomic chemotherapy, and we added intravenous nivolumab with it. And the dose of nivolumab we selected was 20 mg. This was on the logic that the average weight of an Indian is 60 kg, and a 0.3 milligram per kg dose would give you a dose of 18 mg. And we actually, looking at the pharmacokinetic schedules, we decided that there is no need to give it 2 weekly. We would give it 3 weekly. So it was actually nivolumab 20 mg flat dose given 3 weekly. Now, during the period of the study, the nivolumab was spread between the patients. So patients shared the vial of the nivolumab. Now, there's good data which has come from Japan and also from US that even if the vial is open, the vial can be, the active component is okay for nearly 28 days. So vial can be kept, the patient can use the vial for another dose also. The primary endpoint was overall survival. The secondary endpoint was progression-free survival, quality of life, and adverse events. This was the sample size of the study. This study actually had a planned interim analysis, which our IC wanted us to do because they wanted to see whether their concern what this might be a futile attempt also. So the first interim analysis was supposed to happen after we had 75 events, and the nominal P for stopping was 0.006, which means that if you do a OS analysis and if the P came below 0.006, then we would stop the study for efficacy, which exactly happened in this situation. The study was stopped at the first interim for efficacy and was reported. So 151 patients were randomized at the time when the study was stopped, 75 in metronomic and 76 in metronomic plus nivolumab arm. And there was good reception of the treatment in whichever arm the patient was there. For intention-related analysis, all patients were included. One patient in the metronomic arm had to be withdrew, and this was because initially the patient was deemed as unresectable and he was planned for palliative therapy. However, this patient on subsequent referrals to seniors was found to be resectable and underwent a high temporal resection, and hence as the intent of the patient had changed, we had to withdraw that patient. So for per protocol analysis, we had 150 patients and all patients were included in the intention to treat analysis. If you look at the baseline characteristics, you could see that we enrolled PS0 to 1 patients. Around 10 to 15% of our patients were elderly, and it was defined as 60 or above. As the study was done in India, and it's no surprise that greater than 90% of our patients had oral cavity primary. If you look at the PDL1 score, you could see that the PDL1 was not possible in around to be done in around 10% of the patients, but overwhelming majority of the patients had a high PDL1 score of 1% or more. We couldn't look at the CPS. These are the TPS scores which have been reported. Most of the patients were previously treated. So this is a cohort of patients where nearly 2/3 of the patients have received some form of previous therapy. Nearly a large number of these patients, nearly 54% of patients are already exposed to chemotherapy, and most of them are exposed to both taxane and platinum. And if you could see, nearly 60% of these patients had actually failed within 6 months. So what I'm trying to make here, this is actually a very poor group of patients which have failed. And upfront patients who had good performance were actually in a minority of around only 30 to 40%. We observed actually very good responses with this drug. So you could see that this is a pictorial representation of one of the patients where there was within a few months, the tumor had nearly disappeared in this patients. And what we observed in our JCO publication that triple metronomic gave a response rate of 42.9%, we were able to recapitulate that response rate again. And all of the scans were reviewed by us, by the investigator radiological team, and was this response rate is according to assist. We got a response rate of nearly 50% the triple metronomic arm, and additional nivolumab actually led to enhancement in the response, and it was nearly 65%, though it was not statistically significant. What you could see in this curve is that not only the response rates increased with addition of nivolumab, even the depth of response was increased with the addition of nivolumab. This addition of nivolumab led to an improvement in progression-free survival. The 1-year progression-free survival jumped from 3% to 27.5%. The hazard ratio was nearly 0.564. The study met its primary endpoint. In fact, the study had to be stopped at interim analysis. At this, the P which came was 0.00358 for the hazard ratio, which was lesser than the 0.006, the nominal P. The 1-year overall survival improved from 16.3% to 43.4%, making this is a positive study. When you looked at the adverse event, and this doesn't come as a much surprise, additional low-dose nivolumab, many of us must have given it on some or the other time at compassionate ground. It actually didn't lead to a much increase in any of the side effects. Even the side effects of potential interest like pneumonitis, nephritis were not increased with addition of lower doses of nivolumab. We actually did a quality of life analysis also, and when the study was done, we didn't plan to do quality of life analysis in the classic way in which it is done, where you just look at the scores. What we decided that we would do a proper robust quality of life analysis in which we would look at what is the time to deterioration in quality of life, and we compare that with the Kaplan-Meier curve in between both the arms, and both Kaplan-Meier comparison and a hazard Cox regression comparison would be done, and you could see that addition of nivolumab led to improvement in physical functioning, role functioning domains of the quality of life. What does this mean in terms of cost effectiveness to our patients? We have not done a formal cost effectiveness analysis. This is the cost of only of the drugs. So what would be the cost of the drugs? This doesn't take into account cost of administration, adverse events, cost of supportive care. You could see that the Keynote 048 regimen, and this cost is with respect to the cost of drugs, which is in Tata Memorial Hospital, and this might vary according to hospital. This would be the cost in US dollars for Keynote 048 regimen for 1-year schedule. If you look at the triple metronome TMCI, this is the cost. This is nearly 95% absolute decrement in the cost, which could be achieved by giving this drugs in low dose. In terms of Indian rupees, in Tata, the cost of Keynote 048 regimen would come to the tune of around 60 to 62 lakhs, which triple metronomic plus immunotherapy combination would come to the tune of around 3 to 3.5 lakhs, which in most states would not be much different, and would actually come in the gamut of the Ayushman Bharat Yojana, and this will be come within the gamut of Ayushman Bharat. So to conclude, this was the first ever randomized study in which head and neck cancer patients were received palliative metronomic chemotherapy. And then the addition of low-dose nivolumab led to not only to an improvement in overall survival, it also improved the quality of life, the progression-free survival, and the response rates. And we feel that this is an alternative to those patients who cannot access full dose of checkpoint inhibitors. I need to thank the funders. The funder for the study was Motivation for Excellence, Mumbai Oncology Association, Natco Pharma, and Intas Pharmaceuticals, and the whole team of medical oncology, Dr. Kumar sir, in whose guidance this whole study was done, Dr. Vanita Narona, my colleague Dr. Nandini Menon, my students and my colleagues and my coordinators who worked very hard for the recruitment of this study. With that, and thank you for your patient hearing.
Thank you, sir. Thank you so much for the wonderful presentation and the tremendous work. So now I would like to invite Dr. Preeti Agrawal to take us through the next session. Dr. Preeti Agrawal is Consultant Medical Oncologist at Apex Hospital, Jaipur. Over to Dr. Preeti Agrawal. Okay, so shall I invite to chair the next session, Dr. Lalit Mohan Sharma sir. Dr. Lalit Mohan Sharma sir is a senior consultant hematologist and medical oncologist at Mahatma Gandhi Medical College, Jaipur. Welcome, sir. And for the next talk, I would like to invite none other than Dr. Naresh Somani sir. Dr. Naresh Somani sir is a well-known medical oncologist of India. He is the Director Oncology and HOD Medical Oncology at SCG Cancer Center, Jaipur. and he would be delivering the next talk on pre-operative immunotherapy in locally advanced head and neck squamous cell carcinoma. Over to Dr. Naresh Somani, sir.
So thanks, Dr. Lalit Sarma, and thanks to Dr. Lalit Mohan Sarma also. Just to record, I would like to say to Dr. Lalit Mohan Sarma that he has been introduced by me in the very beginning, thinking that he will be starting the session. So, Dr. Lalit, with your permission, I would like to start my topic. Good thing is that we are well in the time, and as Dr. Vijay Patil was presenting just now, the low dose immunotherapy, that how it can be extrapolated, how it can be used, especially in the resource constrained settings like ours. Most of our head neck patients, they are from the poor or the lower socioeconomic group. So how the drugs like the immune checkpoint inhibitors in a low dose or metronomic ways, it can be utilized with the improvement in the result. So same way, the IO, which has been proven in the relapse refractory setting in the first line, second line in the single agent, they have been studied in the pre-operative setting also. Now, in contrast to the relapse refractory setting, there are certain differences in the pre-operative setting in locally advanced head and neck cancer, and that gives the reasons that even a different schedule, the minimum schedule or the minimum duration of the immune checkpoint inhibitors can give the gratifying results in this particular scenario. So as we all understand that the curative intent treatment in locally advanced head neck cancer is either surgery and post-op RT plus minus chemotherapy or radical dose RT with the concurrent cisplatin 3 weekly or maybe weekly, or if the cisplatin ineligible patient, then carboplatin 5-FU doublet or cetuximab. RT plus chemo with nemotuzumab is another approach which is being studied well, I believe so, and being approached, being utilized also in certain subsegments of our patient. And laryngeal hypopharyngeal cancer immune checkpoint inhibitors followed by locoregional therapy like surgery or RT is another way with the aim of the organ preservation. So this is what in nutshell, the curative intent treatment in head neck cancer remains as on today. Now, the rationale to think more, because we know that the results of the locally advanced head neck cancer, in spite of the curative intent, remains poor, and approximately 40 to 50% of the patient only have the 5-year survival, little bit better results in the HPV positive patient. Once loco-regional or the distant recurrence or relapses is there, the prospect for the curative treatments are limited only for the few patients who comes in the purview of the surgery. Now, immune checkpoint inhibitors has emerged as one of the pillars in the head neck cancer malignancy, especially in the relapse refractory or metastatic disease. And with the success in the first line or second line, they have been assessed in the in combination with the surgery, with the RT, with the chemotherapy in adjuvant setting or as a concurrent treatment to improve the curative intent treatment outcome. Setting this all is making the stage for their use in the curative setting in the neoadjuvant or adjuvant or the concurrent scenario. And especially if we talk about the curative intent with the surgery, they have also been studied. Once again, this thought process of the immune checkpoint inhibitor in the neoadjuvant setting is allowing us to revisit, to reconsider the potential role of the neoadjuvant chemotherapy as a part of the definitive treatment for the locally advanced head neck cancer. We all know that neoadjuvant induction chemotherapy doesn't improve the overall survival in this subgroup of the patient, but they are being utilized for the various reasons to improve the locoregional treatment delivery, especially the radiotherapy. But when we combine them with the immune checkpoint inhibitor, that has given the thought process that can it actually improve the outcome of the patient. The various practical applications for this is the success of the neoadjuvant immune therapy before surgery with or without adjuvant treatment offers the prospect of using the tumor for in situ anti-cancer vaccination before the definitive local treatment. That means we are actually making the vaccination effort, and data has demonstrated the potential applications in the neoadjuvant and in adjuvant setting also. But the enthusiasm for the immune checkpoint inhibitor concurrent with the RT has been tempered with the so far available dismal results, or there is a no improvement, positive impact. The further research needs to focus on defining the schedules and the predictive and prognostic biomarkers for the rational selection. So we need to identify those patients who actually can be benefited. Now, various biomarkers, whenever we talk about the immune checkpoint inhibitor, they come in our mind, has been well studied, well utilized also in the various settings, including head and neck cancers are like the PD-L1, TMB, tumor infiltrating lymphocytes. And as far as the head neck is concerned, like smoking versus no smoking, HPV positivity versus negativity, and almost all of them have been studied, but so far nothing is conclusive as far as the neoadjuvant setting is being considered. Pros and cons of the immune therapy in the neoadjuvant, especially before the surgery. Anatomical pros are like the tumors are easily accessible, their drainage lymph nodes are easily accessible, clinical examination also, as well as by the radiological examination also. And I just said that there are various immunological benefits also, like these tumors has the high tumor mutation burden, PD-L1 positivity is very high, high CD8 T cell infiltration also, and it may actually give the vaccination effect also. And clinical implications of the pros are like higher response rate of the IO has been demonstrated in the earlier stage of the malignancy. And there is a potential for IO and chemo plus IO combination. And it may allow to introduce the post-IO therapy de-escalation also, depending on the response. Now, neoadjuvant chemotherapy may have the certain drawbacks also potentially, that it may delay the surgical treatment. Certain patients from the purview of the curative treatment may go in the non-curative or metastatic setting also. There are no established criteria for the extent of the surgical resection. Radiological pathological response, again, there are no established criteria that how to evaluate best way in a uniform way post-new immune checkpoint inhibitors. And overall response in the metastatic setting, as we know, is not more than 25%. And then, yes, of course, there is a potential toxicity also before the surgery, for which the surgeons always remain skeptical. Now, combining immune checkpoint inhibitor with the surgery, the possible benefits, as we just discussed, like expanding the anti-tumor immunity memory cells against the tumor-associated antigens before their en bloc surgical removal, and potential downstaging, which is maybe more effective, less morbid surgery may be possible, and favorable modification of the need for the adjuvant post-operative RT with or without chemotherapy is possible. It may improve the local, regional, and distant disease control with the reduced treatment-related toxicity. So these are the various pros of the immune checkpoint inhibitor. Now, immune checkpoint inhibitors around the surgery or around the radiotherapy in the locally advanced head neck cancers may be applied in the neoadjuvant along with the concurrent RT, or maybe in the adjuvant setting. So in the various ways, it can be applied. A lot of trials are ongoing, a lot of trials are coming. If you divide these trials before surgery, along with the RT, or after the definitive local treatment, they may be in the three setting. We will be basically discussing about those trials which are before the surgery. The RT plus immune checkpoint inhibitors, as on today, have not given any positive impact. Now, out of these various trials, 2-3 points which has emerged, that even the short duration of the immune checkpoint inhibitors with or without chemotherapy is giving the very high response rate. Even the stereotactic brachy-RT has been combined with the immune checkpoint inhibitors before surgery without delaying the surgery, without delaying their outcome. The primary endpoints of the early phase 1 and 2 included the safety, pathological response, and radiological regression criteria. Now, the pathological tumor response which has been studied in this particular field is like PTR0, 1 and 2. PTR0 is no or less than 10% response, while PTR2 is 50% or more response. Other way to say it, pathological response rate, pathological complete remission, where all cancer cells are ablated. Major pathological response criteria means when there is less than 10% cells are viable in the surgical specimen. And immune mediated resist criteria may also be applied, but they remain insufficient as the time course for the immune checkpoint inhibitors, which are being applied in the neoadjuvant setting before surgery, is very less period. So may not be a good criteria. Lot of ongoing phase 2 and 3 immunotherapy trials in head neck cancer are there. And few of these trials, I would like to draw your attention. Keynote trial, where the pembrolizumab is being studied, and neoadjuvant nivolumab with or without EP is also being studied. Keynote 689 is the trial which is about to give its outcome. That's what's come out of this trial. And I was surprised to understand before starting today's webinar, when I was talking to Dr. Govind Babu, he informed me that IM-VOG, this name of the atezolizumab-based trial. We know that various IM powers, IM Viger, and IM patient trials are there in the various settings. But this IM-VOG is based on the ESCO president. The name has been created to his contribution in the field of the oncology. So this is a locally advanced head neck cancer treated with the curative intent, followed by atezolizumab as the adjuvant treatment versus placebo. So this is how the various trials in the neoadjuvant and the adjuvant setting are being discussed and being studied. The immune radiotherapy followed by surgery is the another way, where the stereotactic brachy-RT along with the nivolumab, 24 gray fractions in 3 or 40 gray in the 5 fractions over a period of 1 week has been studied. And these are the well tolerated, and you look at the major pathological response to the tune of 86% and the pathological complete response 67%. And there was no delay in the surgery. So these sort of the protocol need to be studied in much larger randomized trials based protocols. The Keynote 689 trial, a large phase 3 registration trial, it's ongoing. 600 patients, previously untreated, high-risk, resectable, locally advanced head neck cancer. Arm A is the neoadjuvant pembro and surgery, followed by standard of care adjuvant therapy, that is the RT plus minus chemo plus adjuvant pembro, versus surgery followed by standard of RT plus minus chemo as the second arm. Keynote 689, the primary endpoint is the major pathological response and event-free survival. Secondary endpoints are the various like overall survival, clinical partial response, and quality of life parameters outcome. Now, this delay in the curative intent surgery always remains in the mind of the researchers, in the medical oncologists, as well as in the surgery, because tumor may progress or there may be the metastasis in a certain segments of the patient. Unfavorable consequences may be there. This is a situation similar like the esophagus malignancy, where we give the neoadjuvant CT-RT to improve the results of the surgery or the oral result. So the combining the chemotherapy along with the immune checkpoint inhibitor is another way. Induction chemotherapy, as we all understand, there is a minimum survival benefit before the definitive CT-RT, but it has shown the substantial pathological response. And there is always a limitation because of the toxicity. A longer neoadjuvant phase may be required in this particular situation due to the longer median time to response relative to the chemotherapy. So that is the drawback of the immune checkpoint inhibitors. And this is basically because to maximize the proportion of the patient who have an MPR, to improve the depth of the response, and to possibly delay in the curative treatment. So these are the various factors to look into the mind when we study the immune checkpoint inhibitors in the neoadjuvant setting. The combination should allow more rapid and enhanced response. And we have experience of combination of the chemo plus IO. So combining the chemo plus IO in the neoadjuvant setting should not be a problem, because we have now the studies approval of this sort of the combination in the relapse refractory or the metastatic setting. The potential benefits may be like greater radiological response. It might allow for the less extensive and less morbid surgery. And it may allow the disintensification of the adjuvant therapy in these patients who achieve major pathological or clinical partial response, especially the post-operative radiotherapy plus minus chemotherapy. Now, another way which has been studied is the neoadjuvant nivolumab combined with the weekly paclitaxel. And out of this small trial, 26 patients, 69 achieved the major pathological response. And one ongoing study where another drug, semiplimab, immune checkpoint inhibitor, along with the target therapy, cetuximab, along with the chemotherapy, to understand the ability to reduce the extent of the surgical resection and down staging to reduce the post-operative adjuvant RT plus minus chemotherapy. So it is reasonable to anticipate immune checkpoint inhibitor with chemotherapy. They are likely to reduce the extent of the surgical resection. They may modify the post-operative treatment, adjuvant treatment, and may convert the unresectable locally advanced head and neck cancer into resectable disease and generate the anti-tumor memory T cells, potentially reduce the likelihood of the regional and the distant recurrence. So these are the potential or the theoretical gains which are we going to gain once we apply the neoadjuvant immune checkpoint inhibitor. And more than a dozen phase 1 and 2 trials with the neoadjuvant ICI in this particular field has reported results so far. Neoadjuvant single agent or combination IO do not delay the surgery. That also has been seen. The surgical outcomes parameters also remain the same. And most trials are using the immune checkpoint inhibitor related pathological response criteria, but there is a lack of the consensus for that. Neoadjuvant immune therapy in squamous cell cancer may allow for the post-ICI treatment de-escalation. So these are the potential gains. Another way is to say that neoadjuvant immune therapy trials are endorsed by the strong biological and the anatomical rationale. These rationale establish head and neck cancer as an ideal model for the study of these drugs in the neoadjuvant setting. And several neoadjuvant immune therapy trials have been demonstrating that single agent or combination of the chemo plus IO are safe and it's a doable, are not associated with the surgical delay. So notable pathological response are common even with the single dose of the ICI with the higher response rate being achieved with the chemoimmunotherapy combination, and in selected populations such as the HPV-related oropharyngeal cancer, it's giving them remarkable results. While some studies have reported longer disease-free survival, larger studies are still needed to confirm these promising results. And design of the future trials should be biomarker guided in order to achieve the better results, to define the disease nice and the optimal therapeutic combination outcome, where ICI may be more effective in the neoadjuvant, especially before the surgery. And ultimately, to me, at least the future looks bright at the ICI as part of the curative intent treatment. And there is a cause for this optimism. There is a logistic for that also, logics also. So with this, I would like to conclude that immune checkpoint inhibitors are very soon going to come before surgery in the neoadjuvant setting also in the locally advanced head and neck cancer. Thank you.
Thank you, sir, for such an enlightening talk. So, do we have any questions? So let's move forward. So our next session, let's move forward to our next session. Which is sponsored by BMS, and which is the speaker is Dr. Devvrat Arya. He's HOD at Max Hospital. Over to you, sir.
Okay, so thank you very much for this opportunity to present in front of all of you. I hope my slides are visible and I am audible. Okay, so I think we've had some wonderful presentations. The previous speaker, Dr. Somani, was talking about the role of immunotherapy in the neoadjuvant setting. Earlier, we heard Dr. Vijay Patil talk about his excellent study that was presented at ASCO this year with low-dose immunotherapy with metronomic therapy in recurrent metastatic head and neck cancer. And I think we also know, and his data has also shown us how access to immunotherapy has been a little bit of a challenge in our patients. So I'll go back to where it all started. and I will go back to the role of optimizing treatment for recurrent metastatic squamous cell carcinomas with immune checkpoint inhibitors, and particularly the Checkmate 141 study, which was the first randomized trial to evaluate role of immunotherapy in this setting. And I think in many ways it changed the paradigm of treatment of this otherwise a very difficult and very challenging disease. So we know that head and neck cancers can have major physiological, social, psychological impact. When patients suffer from this disease, we are actually talking about important functions like breathing, swallowing. There are concerns in the minds of patients how treatment effective or how effective the treatment is going to be, but also about what are the impact of treatment is going to be in terms of functionality, cosmetics going ahead in the future. I think there clearly is a huge unmet need in the treatment of these patients. Now we know that what we have recognized and increasingly evolving are multidisciplinary models in cancer care, which includes not only multidisciplinary discussion, creation of treatment algorithm for standardization, but also importantly, appropriate decision making. And to come to the optimal solution for patients, it's very important to collect information, not only the data, but also patient-related information, age, comorbidities, so on and so forth, and to ask the right question and listen to different arguments. We know that MDT approach is extremely important, and increasingly, it's not just the medical radiation and the surgical oncologists who constitute the MDT. It's the plastic surgeon, it's the dentist, it's the whole supportive care team with the physiotherapy, the speech and swallowing expert, the dietitian, the nutritionist, the pathologist, and obviously we can't forget the important role of diagnostic and intervention radiology. So coming to head and neck cancer, they constitute 20% of all tumor burden in India, substantial tumor burden. When you look at head and neck cancer as a single subsite, it's responsible for nearly 250,000 new cancer cases every year. And that's when you class all the head and neck subsites together. We also know that, unfortunately, and this is Western data, and I suspect the Indian data is going to be worse, but nearly 50% patients with head and neck cancer relapse. Quite clearly, the likelihood of relapse will depend on the stage of the disease. We know higher the stage, greater the likelihood of relapse. We also know that the timeline of relapses within the first 2 years, majority of relapses can be local, but there's a significant number who have a relapse in both regional and then a small and definite number who will have relapse in the distant sites. Now, when you talk about medical oncology, chemotherapy, systemic therapy for head and neck cancers, we all know platinum-based therapy continues to be an important regimen for the locally advanced squamous cell carcinomas, head and neck. Single agent cisplatin is one of the most commonly used treatment in combination with RT. I think we've discussed the two different regimens, the high dose cisplatin and weekly cisplatin. Increasingly, evidence, suggesting that weekly cisplatin could probably be as good as any other regimen. And we have had various publications. And if you look at the evolution of data, single agent cisplatin still remains one of the key drugs to be used by doctors in the treatment of locally advanced head and neck cancer. But when it comes to recurrent metastatic squamous cell head and neck cancers, the outlook remains poor, particularly for those patients whose disease progresses on platinum-based therapies because of the fact that the choices of treatment so far have been very limited to drugs like taxanes, methotrexate, metronomic therapy, and outcomes overall have been, I dare say, very dismal with these agents. Responses have been rare, progression-free survival has been short, and so has been the overall survival. Now, what was increasingly recognized in the early years of the previous decade was that squamous cell carcinoma is an immunosuppressive tumor. There's a lot of immune modulation that occurs on multiple levels. We know that CD8 plus T cell counts are reduced. They display defects such as low responsiveness to cytokines and reduced proliferative ability. We know that the Th2 phenotype is favored. We know that the treatment associated macrophages secrete immunosuppressive molecules which impair CD8 plus cells, promote Treg production. They also soluble factors like cytokine profiles, which are very immunosuppressive. We know that the NK cell activity is impaired, and the dendritic cell tumor, the maturation is of dendritic cell is prevented, leading to T cell dysfunction and increasing Treg production. And overall, all of this adding up to a very immunosuppressive environment for all squamous cell carcinoma head and neck. Now, coming to nivolumab, this was one of the first anti-PD-1 antibodies, the fully human IgG4 PD-1 receptor blocking monoclonal antibody. Inhibits some major immunosuppressive mechanism directly at the tumor site. It prevents inactivation or reactivates the ability of T cells to attack the tumor. It binds to PD-1 receptors on T cell with a very high affinity, and thereby selectively disrupts inhibitory signaling triggered by PDL1 and PDL2, and it restores normal T cell anti-tumor function as well. So Checkmate 141 was one of the first studies, and I'm going to, in short, discuss the updated results, the 2-year update from Checkmate 141, outcomes with nivolumab versus investigator's choice in recurrent or metastatic squamous cell carcinoma of the head and neck in the overall population and the PDL1 subgroup. So just to remind everyone of the study design, this was a randomized open label phase 3 trial in patients with recurrent metastatic head and neck cancers who had progressed on or within 6 months after platinum-based therapy, including all subsites, that's oral cavity, pharynx, larynx, not amenable to curative treatment, had to have progression on or within 6 months of the lost platinum, had to have an excellent performance status, and patients were enrolled regardless of PDL1. They were randomized 2:1 to either Opdita, that's nivolumab 3 mg per kg once every 2 weeks, or treatment of investigator's choice, so methotrexate, which till then was the standard of care, weekly at 40 milligram per meter square, or the patient could receive docetaxel again weekly, or cetuximab. The primary endpoints for overall survival, the other endpoints which included progression-free survival, overall response rates, duration of response, safety, biomarkers, and patient-related quality of life. So this is the table showing patient baseline characteristics and previous therapy. So median age around 60 years, a significant number of patients being more than 75 years, nearly 80% patients giving, 70 to 80% patients giving history of prior tobacco usage. When you talk about subside, 40 to 50% of subsides accounted by oral cavity, and I think this is very relevant to the Indian setting. And while number of previous lines of therapy could be any, there was a significant number of up to 20% patients who had actually received more than 3 previous lines of therapy, and in various settings, including adjuvant, neoadjuvant, primary disease, as well as metastatic. So the data that we are going to present is actually relevant to treat patients across subgroups. So, we have data and outcomes as per age, HPV status, intent, we have data for the entire intent to treat population. We're also looking at relevant factors like best overall response, whether these patients receive nivolumab immediately in the first line in the metastatic setting, data for the Asian subset, as number of patients are increasing with the usage of cetuximab. It also evaluates patients who have had prior cetuximab. And importantly, we will also look at how the treatment impacted quality of life. So what about results? So when you look at 2 years, nivolumab tripled the survival benefit at 2 years. And I think this is very important. The median OS was 5.1 months for the investigator's choice treatment, and what is improved to 7.7 months with Opdita with a hazard ratio of 0.68. And again, at 2 years, only 6% of patients on immunotherapy survived, and the number improved to 17% for those patients who were on the nivolumab, and this translated into a 32% reduction in risk of death at 2 years as compared to the investigator's choice treatment. The greater survival benefit was also coupled with more durable benefit. So OS benefit observed with Opdita. So 1 in 6 patients were alive at 2 years in Opdita compared to 1 in 16 only for chemotherapy. Similarly, duration of response 9.7 months with nivolumab compared to 4 months with either chemo or cetuximab, that is the investigator's choice, that's IC. And This was clearly a significant benefit. It also importantly demonstrated OS benefit regardless of PDL1. So when you look at the subset of patients who are PDL1 negative, improvement in overall survival with a hazard ratio of 0.73. And when you look at the PDL1 positive patient, that's PDL1 expression of 1% more, the benefit is even more impressive with a hazard ratio of 0.55. Now, when you look at what were the patients who were enrolled in the study, so you had all sorts of patients. We had patients who had localized disease, who received induction chemotherapy or CTRT with platinum or adjuvant RT with platinum, and had progression within 6 months for the latter two subgroups, or patient who had received neoadjuvant chemotherapy and had disease progression immediately. We also had patients with other treatment with curative intent who had showed disease progression. So we practically had a subset of patients who were receiving nivolumab as the first line therapy in the recurrent metastatic setting because they had progressed within 6 months of their last platinum. And we also had patients who had previously platinum as in the first or second line and then had disease progression and then received nivolumab either in the second or third line setting. And in fact, only about 21% patients received nivolumab as the first line treatment in this study. So clearly the other question that comes to mind is, how does the data stack up for those patients who received nivolumab earlier compared to nivolumab in the second or third line setting? And this was a post hoc analysis where outcomes were analyzed in patients depending on whether they received first line therapy or later. And as I said, 21.6% patients received nivolumab in the first line setting. And when you look at results, I think the survival benefit, which was twice for the intent to treat group, was actually even higher for patients who received nivolumab in the first line setting. So 3.8% for the IC group and improving to 21.6%. So this translates into a 46% reduction in the risk of death for those patients who received nivolumab earlier in the first line setting rather than later in the subsequent line setting. Again, overall response rates remain a challenge. We know that in the platinum refractory subgroup, overall responses are rare, and this is quite clearly evident when you look at the IC group, which is overall response rates are only about 3%. This is certainly improved to 10% with the nivolumab arm. The median time to response is fairly equivalent for both the arms at about 2 months. Coming to quality of life, the study showed that Opdivo stabilized quality of life measures versus clinically meaningful deterioration for the investigator's choice treatment. So you had improvement in physical functioning, you had reasonable stability in a slight improvement in role functioning and social functioning with nivolumab. When you talk about overall symptom burden, nivolumab improved or at least stabilized symptom burden, particularly fatigue and to some extent dyspnea and loss of appetite, and also a significant improvement in pain, sensory problems, and stabilization in social contact issues as well. Importantly, when you look at patients who did achieve a response, these patients actually benefited tremendously. So this subgroup of those patients who achieved a CR or a PR, there was actually an 88% reduction in risk of death. And median OS was not reached in these patients with CR and PR compared to 13.6 months with the IC arm, and the 18-month survival rate by 86% for nivolumab compared to 38% for those patients who received treatment and investigator's choice. But then obviously this brings us to the question whether the benefit was driven by these patients, but the answer is no. Opdivo also demonstrated survival benefit in those patients who achieved a stable disease. And these patients typically are not responders, but the median OS was longer, improved from 7.1 months in the IC arm to 10.4 months with nivolumab, with an 18-month survival rate, nearly 3 times with nivolumab at 32.6% compared to 11.7% for the treatment of investigator's choice. Another relevant question, what happens with patients who have had prior use of cetuximab? So even those patients who had had a prior use of cetuximab, improvement in outcomes at milestone analysis at year and a half, clear improvement in the number of patients alive, and also similarly a significant improvement in even in those patients who have not had prior cetuximab exposure. So clearly benefit in outcomes for those, both the subset of patients and markedly so for those patients who did not have prior usage of cetuximab. Again, what about impact of age? So clearly, when you look at hazard ratios, clearly irrespective of age, patients less than 65 or older than 65, patients randomized to receive nivolumab having longer outcomes compared to those patients who received patient treatment investigator's choice. Similarly, no impact of HPV status, fairly impressive improvement in outcomes with nivolumab irrespective of HPV status. What about the Asian subset? And I think this is a very important aspect of the analysis. So when you look at the data on the right side of the screen, that's the Asian subset. So the median OS actually doubled from 6.2 months for the investigator's choice treatment to 12.1 months for nivolumab. And when you look at the milestone analysis at 1 year, 50% of patients alive on the nivolumab arm compared to 27% in the investigator's choice arm. And again, barely any patients survived beyond 16 months in the IC arm, whereas nearly 1/5 of patients were alive at 2 years. And in the Asian subgroup, there was a 59% reduction in risk of death. Clearly, this seems compares much more favorably to the overall intent to treat population. Again, so clearly, I think the data showing that there's a significant improvement in outcomes irrespective of age, performance status, prior cetuximab use, the kind of treatment offered in the IC arm, the subsite, and the prior lines of therapy. Not only the outcomes were improved, Opdita had a favorable tolerability profile. So at 24 months, adverse event rates 4.2% for nivolumab leading to discontinuation compared to 9%. Remember, those patients who were on nivolumab actually had a longer exposure to nivolumab. And similarly, when you talk about grade 3-4 adverse events, 15% for nivolumab compared to 37% for the investigator's choice arm. And the treatment-related side effects are known to us. We know that in small numbers, there are patients who will have fatigue, nausea, anemia, and asthenia. And then we also know that immune checkpoint inhibitors would cause more immune-related side effects as compared to chemotherapy, but clearly much lesser myelosuppression and other side effects that are bane of standard chemotherapy. So what we can conclude is that for patients with recurrent metastatic head and neck cancers on or after platinum-based therapy, nivolumab is the standard of care. It's important to start early with Opdita as the preferred monotherapy. In fact, it's still the first and only monotherapy approved in India for this subset of patients with a superior OS compared to chemotherapy. It's very important to regularly evaluate these patients. In fact, the recommendation is to do evaluation at 9 weeks initially and then 6 weekly thereafter. I know in real world practice, the interval may be different. But I'll quickly conclude and say that head and neck cancer can have major physiological, social, and psychological impacts. It's important to have multidisciplinary discussion that will help provide optimal solution for patients. Nivolumab, that's Opdita, shows survival benefit in platinum-exposed recurrent metastatic head and neck cancer patients. The magnitude of median OS benefit was more than 5 times with Opdita versus the investigator's choice treatment. In the first line subgroup, it stabilized quality of life versus clinically meaningful deterioration in other therapy. And particularly relevant is the Asian subgroup. Opdita demonstrated a 59% reduction in risk of death with a median OS of 12.11 versus 6.2 months for the investigator's choice treatment. So with that, thank you very much for your patient hearing, and I hand the stage back to the organizers. Thank you very much.
Thank you so much, sir, for such an enlightening talk about immunotherapy in head and neck cancers. Do we have any questions? If not, let's move forward to next talk by Dr. Rajat Shah, who is consultant medical oncologist at Max Hospital. Over to you, sir.
Thank you very much to the organizers for giving us the platform to share some enlightening data and to discuss on the various topics pertaining to the metastatic head and neck cancer patients, which is, I think so, one of the very significant problems which we all clinicians have in our life. So let me just share the slide. So I hope I'm visible to all, and I welcome you once again for this talk. Uh, uh, the topic which has been given to me is individualizing the patient journey in a recurrent metastatic squamous cell carcinoma of the head and neck area. So, as has been described in the world, as also in India, the incidence of head and neck cancer is quite high. And India is actually the head and neck cancer capital of the world, with approximately 1/3 of the lip and oral cavity cancers present in India. And this is the Globocam 2020 data. And here, another thing which I would like to highlight is generally across the world, the mortality from the lip oral cavity cancer stands at around 35 to 40%, whereas in India it stands at more than 55%. 60% of the patients have a high, overall a very high mortality for this high frequency tumor. So why is it so that we have got such a high incidence and such a high mortality with this disease? So basically, it is genetically and etiologically, our patient profiles are different, and that has been quite well put by Kumar Prabhash et al. And published in the Indian Journal of Cancer, whereby they have stated that among patients with head and neck cancer, 87% are generally tobacco-related cancers, whereas in the Western world, it is probably lesser use of tobacco and more of HPV-related cancers are there. Amongst oral cancers, tobacco users have been shown to have a poorer survival as compared to non-tobacco users. Definitely 43% versus 72%. And again, compared to the Western world, these patients require an aggressive treatment. So that is also very, very, because our patients present with a higher burden of disease. So they require a more aggressive treatment early on in the phase of their treatment course. So these are the basic differences between the Western world and the Indian world. And sadly, we still emulate the Western data, and we have a lack of Indian data in this respect. So a range of patient-related factors can be considered in the selection of patients, in the selection of the treatment regimen. We can have burden of symptoms, we have the comorbidities, we have the patient perspectives, the performance status, the biomarkers in squamous cell carcinomas, and the tumor characteristics like the volume of growth. And if we kind of combine all these together, then we have to kind of choose the right regimen for the right patient. So patients with recurrent metastatic head and neck cancer have different needs and abilities to tolerate the treatment. And we all would agree that patient would require a treatment that prolongs survival. Yes, everyone wants that. And then patients will definitely have a heavy tumor burden causing symptoms and would require a very rapid response. That is also very important. We should also realize that patients may not be able to tolerate you at the dose prescribed in the extreme trial. Some patients may not be also be able to tolerate cisplatin due to certain cardiac morbidities or some old age. So all in all, to summarize, each patient is unique, and personalizing care for each patient is very, very important. Head and neck cancer has been an exciting landscape. Basically, it started with single-agent chemotherapies like methotrexate, and then combination therapies came. Then there came the the path-breaking extreme regimen, which was published in year 2008, was one of the first trials to achieve an overall survival benefit. Then came the era of the immune checkpoint inhibitors in 2016 to 18. Then came the TP extreme trial. And the side by side came the Keynote 048 trial also. And now in year 2020, we have got exciting data with the sequencing of therapy. So all in all, since the 1970s to year 2020 and 2022, the overall survival has definitely improved from a meager 6 months to approximately 21 months if we intelligently follow the sequence of the TP extreme followed by immune checkpoint inhibitors. So just a snapshot of the various important trials in the first line therapy. We all are nowadays following the TP extreme trial. The TP extreme trial had taxane, docetaxel with cisplatin or carboplatin, Q3 weekly, along with cetuximab, which was initially given weekly. The chemotherapy arm was limited to 4 cycles of chemotherapy, and then when the patients went on to cetuximab maintenance. So this was the TP extreme trial arm. The extreme trial arm obviously was the cisplatin 5FU standard 5-day regimen along with cetuximab for 6 cycles followed by cetuximab weekly maintenance. This trial essentially it was kind of in the primary endpoint being overall survival. It was almost overlapping with 14.5 months versus 13.4 months. Not much difference between extreme and TP extreme in that respect. In the secondary endpoint, the progression-free survival, also the TP extreme arm was almost equivalent to the extreme arm. And in the quality of life indices, the TP extreme arm fared slightly better. Overall, the quality of life indices was slightly better for the TP extreme arm as compared to the extreme arm. So all in all, when a drug regimen is giving almost an equivalent survival rate and equivalent progression-free survival, then what decides which drug we should use? It is the ease of administration and the quality of life indices, and that is where the TP extreme trial scores over the extreme regimen. This is another very significant trial which is trying to change our practice, is the Keynote 048 trial, which kind of showed that pembrolizumab plus platinum 5FU is showed an improvement in the overall survival vis-a-vis the standard extreme trial arm, and in the CPS score greater than 20. Also, the pembrolizumab monotherapy arm also showed an improvement in the overall survival. So based on this trial, the pembrolizumab platinum 5FU was the standard of care option. But here it is a caveat. It's not for all comer patients. It is only for the survival benefit is mainly seen with whose PD-L1 CPS score is greater than or equal to 20. So that is an important caveat, and that comprises approximately 43% of our head and neck cancer population, not all. So we need to select our patients before we embark upon the immunotherapy chemotherapy combination. Keynote 048 showed that the pembrolizumab arm had almost an equivalent quality of life indices as compared to the extreme arm. So not much to discuss over here. They almost had a similar kind of a quality of life issues as well as toxicity profile. So these were the two major, basically major forms of treatment, I would say. One is the cetuximab-based chemotherapy-based treatment, and one is the immuno-oncology drugs-based chemotherapy treatment regimen. So what basically decides which treatment to give to which patient? One is the need for response. Need for response is dictated by the burden of the disease, the pace of the disease, and the symptoms with which the patient is coming to the clinic. Second is the comorbidities and also the convenience of the patient. Third, obviously, is the biomarkers, and amongst the biomarkers, we only have currently the CPS score to guide us. Fourth is the performance status of the age of the patient. And fifth is basically the sequence of treatment. When you have got two active regimens, which to choose first, which to choose second. So a patient always has a need for response. Why? Because all the more in a recurrent head and neck cancer patient, because these tumors are located near vital organs, and these can rapidly lead to either a tracheal compression, stridor, or some means compression of the orodigestive tract, leading to dysphagia. All these, so it's a very vital location of these tumors. So we need a good rapid response as the message. Any progression of the first line treatment often leads to rapid deterioration, so that is also needs to be taken into account, and they have very profound negative consequences. Another important thing which I would like to highlight is the concept and the prevalence of hyperprogression during the immuno-oncology drugs. So let us see what is the importance of overall response rates in head and neck cancer patients. So this was a paper by Hecht et al., which showed that tumor treatment response lowers the tumor symptom burden in recurrent or metastatic head and neck cancers. So basically, we need a rapid response, and whichever regimen provides a rapid response, that is definitely beneficial for our patients with a high tumor burden. So let us come to the response rates, which our TP Extreme trial or the Extreme trial gives. At overall response rates at 12 weeks is approximately 57% with the TP Extreme arm, 59% with the Extreme arm. The rate of progressive disease, very important, the rate of progressive disease is only 8% with the TP Extreme arm and only 11% with the Extreme arm. So overall, yes, more than 50% of our patients are getting a benefit, and only 8 to 10% of patients are showing progression. So that is a good figure to tell our patients. And this overall response rate is emulated across various ethnic differences. Also in European patients, also we can see it is ranging around 57 to 59%. In Asian patients, there are two trials which have been quoted in this figure, 50% and 45%. And in elderly and frail patients also, we are getting a response rate of around 40%. So that is extremely encouraging for us. And I have gathered a few more trials, and I would like to just show that there are two trials from India also, whereby the overall response rate with cetuximab and chemotherapy is in the range of 77% and 82% also. So if we are able to intelligently use Erbitux in our patients, then we can get a good response rates for our patient population. So in contrast, now let us see what is the overall response rates and the rate of progressive disease with the immuno-oncology drugs. So if we do pembrolizumab monotherapy in the patients, then in the trial setting, there was approximately a 23.3% response rates. So let us again go back to the TP Extreme arm, whereby 57% response rates were there, and in the pembrolizumab monotherapy, it is 23.3%. So quite a stark difference is there, and this difference should it's a hell lot of a difference in a patient who's symptomatically who has a high symptom burden, I would say. Another thing which I would like to point out here is the rate of progressive disease is a whopping 31% with the pembrolizumab arm versus only 9.8% with the Extreme arm. So this also has a very tremendous impact on means while prognosticating our patients and while starting our patients on the immuno-oncology drugs, we have to explain to the patient that there are risks of hyperprogression. There are risks of a very significant 1/3 of our patients are having some sort of a progressive disease. So are we kind of even in the CPS score greater than 20%? So imagine that we have selected a good population of CPS and still these patients are having hyperprogression of progressive disease. Now let us come to the combination of pembrolizumab plus platinum plus 5-FU. Here also about 15% of our patients are having a progressive disease, vis-a-vis only 8.2% with the chemotherapy arm. So the addition of pembrolizumab is somehow causing more progressive disease when adding to the same chemotherapy regimen, which is 5-FU cisplatin. So this is based, a lot of research has gone into it, and what has been found out is basically a lot of the head and neck cancer patients also harbor the MDM2 mutations. The MDM2 mutations, we generally do not do NGS for our patients, but if the MDM2 mutations are there, then these patients will have hyperprogression while on the immuno-oncology drugs. So that is means a very difficult thing to explain to our patients per se. So so whenever we are in need of a rapid response, hence speaking, we should always try to get a regimen which is showing more than 60, approximately a 55 to 60%, 70% response rate, and that I would say is basically a cetuximab plus chemotherapy combination. And once we have exhausted this combination, and when a patient is progressing, then we can switch over to a immuno-oncology monotherapy arm. There is another way of treating, obviously the Keynote 048 trial, but here, yes, the hyperprogression, the rate of progressive disease, the lower rates of overall response rates, all that has to be taken into account. So now let us come to the aspect of biomarker selection, basically selection of the patient population. We have seen that in all comer patients, probably a chemotherapy Erbitux arm may show a definite benefit. Now, if we are able to select our population by the CPS score by DACO, if the CPS score by DACO is greater than 20, then the pembrolizumab monotherapy gives a good overall survival of 14.9 months, with the extreme trial giving only 10.7 months. So that is statistically significant. So definitely that is what has prompted the use of pembrolizumab in the first line setting. And now let us further dissect the use of pembrolizumab in the recurrent head and neck cancer patients. And in these patients, basically, there are two types of patients. One is only recurrent patients, and one is a de novo metastatic patients. And the smaller intersecting population would be a recurrent and metastatic patients. So I would say, at least in our clinical practice, we have a very high percentage of recurrent head and neck cancer patients. So recurrent head and neck cancer patients who are probably locally recurrent, these are contribute a very high percentage, and de novo metastatic disease is comparatively lesser in our population. So if we are able to dissect out only the recurrent population, let us see what has happened to this population with the use of pembrolizumab. So the extreme trial showed a median overall survival of 12.1 months in this recurrent patient population, and the pembrolizumab monotherapy showed only 11.5 months. In this recurrent head and neck cancer patients, the median progression-free survival was definitely better in the extreme trial. So patients with a recurrent squamous cell head and neck cancer have a high tumor burden, and the symptoms and morbidity are definitely linked to local tumor burden. Now let us come to the convenience and safety of administration. We have all seen that the TP extreme arm has a higher convenience of administration. We can administer the drugs in the daycare itself. No need for IPD administration. No need probably for our central line placement. And so it is, and definitely in the TP extreme arm, the exposure to the chemotherapy is also lesser. It is only up to a maximum of 4 cycles. So ultimately, it is definitely an easier regimen to give. Subsequently, the trial investigators have also proven that if we are able to continue the Erbitux maintenance at Q2 weekly interval, that also is a very important thing. That if we are increasing the basically decreasing the visits of the patient to the hospital, every 2 weekly patient comes for Erbitux maintenance, and that also works very well for us for this. So it is very easy to give this TP extreme arm, and this is again so this is okay. Now let us come to the toxicity of the drugs. Now the platinum plus 5-FU plus pembrolizumab, if we combine all three, the rates of grade 3 to 5 toxicities is in the range of around 85%, and the adverse events leading to discontinuation is in the range of 32%. So that means 1/3 of our patients will be discontinuing the treatment regimen due to adverse events. And adverse events leading to death is approximately 11%. So that is also very important and a high figure, I would say. And now let us look at the TP extreme arm and the toxicity of the TP extreme arm. Here in the TP extreme arm, it is about 75% grade 3 or grade 4 adverse events, and grade 4 or more adverse events is approximately 36%. And we have not seen anyone kind of discontinuing treatment because of side effects. Yes, there are about 10% patients who discontinue treatment because of the side effect profile. So another important unique feature to Indians head and neck cancer patient is the comorbidities. Almost or quite a lot of patients are slightly advanced age. They have higher comorbidities with cardiac, respiratory. Most of them are smokers. They have COPD, and they have oral submucous fibrosis. So all these are there. So cardiac, respiratory, hypertension are major comorbidities in our patients. and that also needs to be taken into account while discussing the treatment modality. And here also, I would say that taxanes are convenient to administer as compared to 5-FU. Generally, we do not test for DPT deficiency in our population, but that is also prevalent, and that kind of impairs the use of 5-FU. It causes more than usual side effects. And amongst the TP Extreme trial, we have, as clinicians, kind of did a little bit of a interchange of the taxanes. We have given paclitaxel weekly regimen in patients who are comparatively having a lower performance scale. So rather than a 3-weekly docetaxel, we can give weekly paclitaxel along with platinum, along with Erbitux, and that also kind of gives a very good overall response rates and survival in our patients. So now coming to the treatment sequence. So what could be the treatment sequence? So either we can choose the immuno-oncology drugs in the first line and move on to the Erbitux arm in the second line, or we could start with the Erbitux chemotherapy in the first line and move on to the immuno-oncology drugs in the second line. So this was the TP Extreme study with the second line immuno-oncology drugs. Now let us see in the extreme arm. In the extreme arm, basically in the extreme arm of the TP Extreme study, patients who were given initially the extreme regimen, which is cis-5-FU, and this was followed by the immuno-oncology drugs. The median overall survival was 19.4 months. So that is a very good median overall survival. And now, if we have the TP Extreme arm, which is the taxane, platinum, and Erbitux, when the patients progress and then the patients go on to receive the second line immuno-oncology drugs, here the median overall survival of this patient is in the range of 21.9 months. So that is a very important milestone in the life of our head and neck cancer patients, if we are able to give approximately overall survival approaching 2 years for our patients. So this is possible due to the exposure of the patients to both the active regimens. First, the Erbitux chemotherapy regimen, which gives a good rapid symptom control, and subsequently we move on to the patients to immuno-oncology drugs down the line, which is comparatively easier to tolerate, and they can achieve a 21.9 months magic figure of overall survival. This is again our own Indian paper coming from Dharamshila Narayana Hospital, a multi-center trial. The investigators randomized 54 patients who were exposed to the paclitaxel, carbopactin, and it is almost like the TP Extreme trial arm, and they had a good overall response rates of 79.7%. Subsequently, on progressions, they were randomized to nivolumab, 19 patients, and the oral metronomic chemotherapy of 10 patients. And then they showed that nivolumab arm, the 19 patients had an overall response rate of 37 months and a median overall, that's a very important, the median overall survival of approximately 20.4 months. So that is a very important figure. Again, it is kind of almost emulating the trial setting. Here also in the TP Extreme arm, it was 21.9 months. And in our Indian investigators, they have also achieved a median overall survival of 20.4 months with the sequencing of cetuximab chemotherapy in the first line, followed by nivolumab in the second line. So that is an important data coming from the Indian subset of population. To end my presentation, we have a paper by Peter Stutz et al. Translating the Keynote 048 into practice recommendation for head and neck cancer. Are we able to and should we give all our patients the immuno-oncology drugs in the first line setting? I would say not. Why? Because now there are various factors which are there. Here we can see that definitely the patients can be platinum sensitive or can be platinum resistant. In our previous talk, Dr. Devrat was talking about the platinum resistant population, whereby nivolumab single agent definitely showed an improvement in the overall survival. Here also in the platinum resistant population also we can do with Erbitux plus taxane regimen minus the platinum that can be given. And in an extremely fit patient, it works better. And however, the immuno-oncology drugs in the platinum resistant patients are preferred. In the platinum sensitive patients who have a higher disease-free survival, more than 6 months, I would say that in almost all the patient population, whether the patient is fit or frail, patient has a high tumor burden, patient has a fast pace of disease, in all these scores, the Erbitux plus chemotherapy arm fares better as compared to the immuno-oncology drugs. So only this factor is there when we have a good biomarker selection of PD-L1 CPS greater than 20. Only in this percentage of population, whereby the pembrolizumab plus platinum chemotherapy or pembrolizumab alone arm would be preferred. In all others, I would say we should prefer the cetuximab plus chemotherapy arm. So with that, I would like to conclude my presentation just by saying that each patient with metastatic head and neck cancer is unique. The treatment decision definitely should consider the variety of patients' need, the need for symptom control, the comorbidities, the cost factor. Yes, very important in our Indian settings. All these have to be taken into control and consideration. Genetically and etiologically, the Indian patients are different than the Western population. Factors like the tumor burden, the pace of the disease, the biomarker status are important in the treatment of recurrent metastatic head and neck cancer. With the ASCO 2020 TP Extreme, basically the sequential arm of cetuximab-based regimen in the first line, followed by immuno-oncology drugs in the second line, had an overall survival reaching 21.9 months. So that is pretty encouraging for our patients. Thank you very much, and open to any discussions down the line. Thank you.
Thanks.
Thank you, sir.
Yeah, please go ahead.
Yeah, thank you, sir, for this talk. I would like to call Naresh Somani, sir.
Is there any question to Dr. Rajat Shah? So if no, then we would like to thank for the very thoughtful, very deep insight, ways to think that how to select the drugs in the or the combination in the first line. And I have seen over the years that moment we have something so-called breakthrough, or which has shown something like the improvement in the PFS or little bit in the overall survival, we just start forgetting that what are the patient population for whom this is the useful, what are the other ways, what had been the other ways treating in the past, and what are the patient selection criteria otherwise. So that's very important, and I would like to congratulate Dr. Rajat Shah once again to bring on the surface that what is the way of selecting the patient for the target therapy versus immune therapy in the first line, and how the sequential treatment may be useful or the equally useful or maybe the more useful in the patient selection in head and neck cancer, which is so rampant or so common in our context. Thanks. And with this, I would like to thank all the previous speakers, also the panelists, the chairpersons also, and the session coordinator, and as well as the sponsors for the head and neck meeting also. And you all will agree with me that the previous speakers like Dr. Satvik Khattar, Dr. Sarthak Tandon, they have done the wonderful job. Dr. Govind Babu remained, as usual, one of the best speakers, and he gave us the new insight in the nasopharyngeal cancer, that how the nimotuzumab can be incorporated, like the head neck locally advanced malignancy. And our next speaker, Dr. Vijay Patil from the TMH. As usual, TMH people, they bring something breakthrough, something practice changing, something cutting the cost, and that always is being admired by all of us across the world. And he brought the data of the metronomic therapy plus minus immune therapy, low dose, that how it is improving, how it is doing the wonderfuls in our setting. And I try to discuss the new adjuvant immune checkpoint inhibitors in the surgical setting, that before surgery, how they are making the difference. And Dr. Devrat Arre trying to put the one point, that is the immune checkpoint inhibitors in the relapsed refractory first line setting. And Dr. Rajat Shah gave us the insight about the patient selection and what is the way to utilize the immune checkpoint inhibitors as well as the target therapy. So with this, I would like to conclude the head and neck session of the BCOS third edition. And we are very glad that we are well in the time, dot in the time. It's 8 o'clock in the my mobile. And with this, I would like to hand over the session to Dr. Prakash Sekhawat, who is consultant hemato-oncologist, hematologist at the National Institute of Medical Sciences at Jaipur, to start the proceedings. And with this, we will switch the gear to the hematological malignancy. Dr. Prakash Sekhawat, please.
Thank you, sir. It was always pleasure to attend these meetings, and the third BCOS is doing very good. And without wasting time, because we are on time, we will be starting our next HEMAT session. First of all, I would like to invite our first speaker for this session, who is none other than Professor Hemant Malhotra, sir. Sir is Director Medical Oncology at Mahatma Gandhi Medical College and Sri Ram Cancer Center. Sir will be speaking, giving his valuable experience and insights on multiple myeloma, high-risk multiple myeloma. In a gist, he will explain everything regarding myeloma. So I would invite Professor Malhotra, sir, to take over and carry forward with his illustrious talk.
Am I visible and audible?
Yes, sir, you are visible.
So thank you very much, Honorable Chairman, my dear friend, Dr. Prakash. And if I can be permitted to share my screen now. So is my screen visible?
Yes, sir, it's visible in slide mode.
Okay,
you can make it on the full screen mode if you wish.
I have made it on full screen.
Yes, sir, it's okay, sir, full screen.
Okay, so my most sincere thanks to the organizers of this meeting, particularly Dr. Naresh Somani. It's very, very impressive to see that this meeting is exactly on time. And that is the hallmark of a very well organized meeting. So I'll just launch into my topic today. My topic today is first line management of myeloma, how best to select. And I bring you greetings from the Mahatma Gandhi Medical College Hospital, and most sincere thanks to the organizers for this opportunity. So before I start, I'd like all of you to join me in thanking this Indian myeloma mafia in the United States. And, you know, we are proud of each and every one of these individuals, and there is hardly any work done in the myeloma front without the presence of these ladies and gentlemen. So like, you know, let's all jointly convey our thanks to all of them for the mark which they have made in the world in the treatment of this disease. And because of their efforts and the efforts of a lot of other experts, both from the laboratory, from the industry, and of course the clinicians, the overall survival of patients with myeloma has been constantly increasing. And you can see the 5-year survival in the 70s used to be about 30%, and it has already gone up to about 60% now. And this is the journey of the various drugs in myeloma, starting with melphalan in 1958, the corticosteroids combinations, high-dose therapy in 1983, then the arrival and discovery of the IMiD, thalidomide, Seema Mehta from Little Rock, and then, you know, the proteasome inhibitors, the monoclonal antibodies against myeloma, and now we are in the era of CAR T cells and T cell engager monoclonal antibodies. So this is the survival curve, overall survival curve of myeloma, which has been progressively increasing from about 3 years in the early part of this decade to 8 to 10 years now. And this is because of the availability of the intensive research. And you'll be surprised to see that in the past 5 years, at least 5 or 6 new drugs for myeloma have been discovered, tested, and FDA approved. And quite a lot of these drugs are available to us in India also. Most of us are aware that if you have a patient suspected as having myeloma, this is the workup which you need to do. You have to have the serum protein electrophoresis, the serum free light chain. You need to assess whether the patient has bone disease by either a whole body low dose PET CT scan or an MRI scan. And of course, a marrow has to be done, and it is now mandatory that at least you get the FISH panel done on the marrow to look for poor prognostic cytogenetic abnormalities. Uh, you're also aware the updated International Myeloma Working Group criteria for the diagnosis. All of us are familiar with the CRAB features, but also please note that they have now added the SLIM criteria. The S stands for 60% monoclonal bone marrow plasma cells. The LI stands for serum free light chain ratio of more than 100. And M stands for MRI showing one focal lesion equal to or more than 5 millimeters in size. And if the patient has any one of the CRAB features or the SLIM features, the patient is a candidate for treatment. The staging system also has been revised. It is now the RISS, and high risk cytogenetics has been included. The LDH has been included, and this separates the 5 years overall survival very nicely, being only 40% in stage 3 disease and 80% in stage 1 disease. When should you treat myeloma? If the patient has any CRAB features, if the patient has any SLIM features, these patients should be treated. And also patients who have high risk smoldering myeloma, because they have a time to progression of only 2 years, it is recommended that either they be put on clinical trials or early therapy, low intensity therapy with either lenalidomide alone or a combination of bortezomib, low dose dexamethasone given to these patients. And once you have a patient of myeloma who is a candidate for treatment, then the first and foremost thing, depending upon the patient's age, fitness, and comorbidities, is that at diagnosis itself, you have to decide whether the patient is transplant eligible or transplant ineligible. For patients who are transplant ineligible, you give them induction treatment. It could continue for a longer period of time also, or you could put them on maintenance treatment. For patients who are transplant eligible after primary induction therapy, you look at the response. For patients who have responded to the induction therapy, all these patients should have high dose therapy with autologous or allogeneic stem cell transplant. And then they should be put on maintenance therapy. Patients who don't have a response have a very bad prognosis, and they should be put on clinical trials. And if they respond to the trial agent or one of the newer agents, which we have for relapsed refractory myeloma, then you could think of, again, the high dose therapy with autologous or allogeneic stem cell transplant if indicated. So today I'm not going to cover the patients of relapse refractory myeloma. I'll try and give you some insight on the patients, the newly diagnosed patients of multiple myeloma. So this is the latest 2022 NCCN guidelines. These are the insights. This is publication for discussion amongst experts. Otherwise, the 2022 guidelines for myeloma, the NCCN ones have not been published. So primary therapy for transplant eligible candidates could be any one of these regimes, the VRD regime or the KRD regime, or a 4-drug regime, which is also now approved: daratumumab, lenalidomide, bortezomib, and dexamethasone. And we'll talk about these in the subsequent presentations. There are several other regimes which are also propagated, and these are listed out here. The maintenance therapy, once the patient goes into a complete remission, is listed again here. It could be, most of the time it is lenalidomide, but it could be one of the more aggressive regimes also. For patients who are not candidates for a bone marrow transplant, these are the regimes which are advised. The preferred regimes are a combination of bortezomib, lenalidomide, dexamethasone, category 1 recommendation, and a 4-drug regime also, a combination of daratumumab, lenalidomide, and dexamethasone, and we'll see some data why this is approved in the first line and why this is the preferred regime for even the non-transplant candidates. This is the recommendation from the joint multiple myeloma group and the ESMO for patients who are eligible for autologous stem cell transplant. The first line option is either VRD or a 4-drug combination of DARA, VTD. If this is not available, then VTD or VCD could also be used as first line treatment. And again, these experts have also emphasized that eligibility for autologous stem cell transplant should be established at diagnosis, because this will impact on the selection of your induction treatment, and this should be determined at the first evaluation of the patient. There is this Cassiopeia study which has compared 4 drugs with 3 drugs, and there is a significant difference of the 4 drugs as compared to the 3 drugs, and we'll talk about this study in one of the later slides. The VRD also is a first-line standard regime producing very high VGPRs and MRD negativity, and this is preferred over VTD because we have level 1 evidence that VRD may be better than VTD. If you move on to the consolidation, in the consolidation for the fit patients, for the transplant eligible patients, this consolidation should be done by 200 milligrams per meter square of melphalan, followed by an autologous stem cell transplant. And this has to be followed by at least lenalidomide maintenance. Some other regimes for maintenance are also described. For the transplant ineligible patient, the first line treatment options are DARA-RD or DARA-VMP or VRD. And if these options are not available or not affordable, then you could also think of bortezomib, melphalan, prednisolone, or lenalidomide low-dose dexamethasone. And these are the various studies. The SWOG 777 study, which proves the superiority of VRD over RD, and the acyclone study, which proves the superiority of DARA-VMP over VMP, and we'll see, and the MIA study, which again says that if you use daratumumab first line, then there is a significant progression-free survival advantage. This again we'll see in the subsequent slides. So now let's talk in a little more details about the newly diagnosed patients with multiple myeloma who are eligible for autologous stem cell transplant. So the important issues in this cohort of patients is whether they should receive a triplet induction or a quadruplet induction, and whether frontline transplant should be offered to them or can transplant be delayed. High-risk disease, should a more aggressive strategy be used, like using 4 drugs for all high-risk patients, or using our more potent second-line drugs like the KRD regime for these high-risk patients. And then maintenance, LEN as a single agent is very well established, but is there any advantage of 2 drugs over single agent? So, some of these issues we will discuss in the subsequent slides. So as I've already told you, shown you this slide, that the first line options in the European Union are a combination of either VRD or DARA-VTD, which is now a level 1 recommendation. And why is this so? This is, the MSMART, some of you would be aware of this. This is the recommendation from the Mayo Clinic by Dr. Vincent Rajkumar. And they again say that 4 cycles of VRD, then you should collect stem cells, perform the transplant, or you could do another 4 cycles of VRD, LEN until progression, and you could delay the autologous transplant. And for patients who have bad cytogenetics, you do need to move the transplant upfront. And for the induction regime, you need to consider DARA upfront, and a 4-drug induction regime is advised. And in the maintenance rather than LEN, most of the experts are advocating, or you could consider bortezomib maintenance. Just 1 or 2 slides on frontline versus delayed autologous stem cell transplant. This was the IFM 209 study, 700 patients, less than 66 years, all newly diagnosed, all given 3 cycles of RBD. And the one group continued with RBD and lung maintenance and a transplant after relapse, and while the other group after 3 cycles of RBD had the transplant and post-transplant consolidation with 2 cycles of RBD. And here are the updated primary endpoint, which is the PFS results for you, almost 90-month follow-up. And you can see very clearly that the transplant arm, the PFS is significantly better than the delayed transplant arm with a hazard ratio of 0.7. PFS in the early transplant arm is 47 months, and in the late transplant arm is much less. So there is a 30% reduction in the risk of progression or death in patients receiving transplant. And it is pretty much standard of care now that for patients who are eligible for transplant, they should receive transplant upfront rather than later. Now, what about triplet and quadruplet induction? We have the Cassiopeia study. This is a phase 3 study of DVTD versus VTD in transplant eligible patients. Look at the number of patients, more than 1,000 patients, and they were randomized to 4-drug induction, and then a few cycles of consolidation, and then transplant, and then maintenance. These are the results for you. If you look at the MRD negativity, the DARA VTD regime was significantly better in producing MRD negativity results. This is the sensitivity of the MRD testing as compared to the VTD regime. And if you look at the subgroup analysis, the DVTD arm is superior across all subgroups, including high-risk cytogenetics and ISS stage 3 patients. So for the right patient, for the patient who can afford the daratumumab, it is now level 1 evidence that 4-drug induction with DARA upfront may be the better choice. And here is the PFS for you, like significantly better, not reached in the 4-drug versus 51.5 months in the 3-drug, hazard ratio of 0.58 and a very significant p-value. There is a overall survival benefit also, but in this publication in 2021, the mature data is not available. Even in this, you can see that the hazard ratio in favor of the 4 drugs is 0.54, with significantly less number of deaths as compared to the 3-drug arm. And this was an abstract in last year's ASH, in which the patients who were on the 4 drugs and who had MRD negativity and who had a complete response, they had a very good progression-free survival. And this group of patients did the best out of all the other group of patients. Now, VRD versus VTD DARA, is there any data? There is a meta-analysis of some studies, the VTD DARA versus VRD DARA, hazard ratio in favor of the DARA arm is 0.3. VTD DARA versus VCD DARA, the hazard ratio is 0.35. And then VTD DARA versus VD, the hazard ratio is 0.3. So there is this is a cross-trial comparison, but there is evidence that if you use the monoclonal antibody upfront in your induction, you do produce significantly better overall survival and progression-free survival. What about VRD, which is our so to say best regime till just a few years back versus VRD DARA? And this is the Griffin study, transplant eligible patients, good performance status, good renal functions, randomized to DRVD versus RVD, consolidation of 2 cycles of the same, and then following transplant maintenance cycles. And you can see that the response rates in the 4-drug arm is significantly better This is the 4-drug arm over here, and this is the 3-drug arm. Complete response rate of 82% versus 60%, and MRD negativity rates again at 24 months, 64% versus 30%. So like a very significant difference. Progression-free survival at 24 months with the 4-drug arm, the DRVD is again significantly better, 89% versus 81%, and a very healthy significant p-value of 0.46. So now we move to current strategies very quickly for newly diagnosed patients that are ineligible for autologous transplants. The important issues here are whether combination with the CD38 antibody upfront, will that increase progression-free survival and overall survival? Studies are ongoing. The use of frailty scores are important, management of AEs are important, and fixed duration of treatment or treatment until progression. This again is an important question which most of us need to ask. And these are the regimes which are approved and described and recommended. A combination of DARA-RV and RD, DARA-VMP and VRD, all these are first-line options. And these are the other options if the first-line options are not available or not affordable. And this is the recommendation from the Mayo Clinic. Their regime of choice is DARA, bortezomib, and low-dose dexamethasone. This was a publication by Dury et al. In which they considered the overall survival as related to age, and they found that VRD was significantly better than RD at all ages, even in patients who were more than 65, 34 versus 24, and more than 75 again. Even in patients who were elderly, they could tolerate the VRD, and it did produce a better progression-free survival. The acyclone study is a phase 3 study comparing DARA-VMP versus VMP, 9 cycles followed by maintenance. And here you can see that there is a difference in overall survival at 75% versus 62%, and a significant difference in progression-free survival as a ratio of 0.2 and a very significant p-value, 36 months versus 19 months. Toxicity in the DARA group, as expected, is a little more, and you have to be particularly careful about chest infections and chest toxicity in the DARA group of arm in these transplant ineligible patients. There's another study which is compared DRD versus RD. This is the MIA study, DRD versus RD. And again, in this study also, there is a significant difference in the PFS as well as the overall survival in the DARA containing arm. So again, level 1 evidence that if you use the monoclonal antibody, even in transplant ineligible elderly patients, it gives a benefit. And this is the frailty subgroup analysis. Patients who are, maybe I can draw your attention to here, even in the frail patients, MRD negativity is significantly more in the DARA arm as compared to the non-DARA arm. And clinical benefit of DRD is there regardless of the fragility status. Toxicities, as expected, are more in the DRD arm. And again, chest infections and pneumonias, you have to be particularly careful of. So if I were to conclude now, last 2 slides, recently approved therapies have changed the landscape of management of myeloma, and at least 8 new agents in the past decades have been approved. New doublets, triplets, and quadruplets, as we've already discussed, should now be considered in the first line, both for transplant eligible and transplant ineligible patients. Transplant eligibility needs to be established at diagnosis before initiating treatment, because it will help you decide what induction treatment to give your patient. And in addition to just chronological age, assessment of frailty by the so many scores which we have is essential component in deciding which induction regime to choose. High dose melphalan followed by stem cell rescue remains the standard of care for the eligible patients. Maintenance treatment should be offered to all patients. A role of MRD in treatment, even though I didn't show you slides on this or talk about this, still is being evaluated and is not as of now standard of care. For the high risk patients with bad cytogenetics or RISS stage 3, a four drug induction or the use of more potent agents like the KRD regime may be more beneficial. And it is very important for us as clinicians to anticipate and prevent drug-related toxicity. And this is absolutely vital for good outcomes. And with that, I thank you for this listening. And I'd like to end with this Winston Churchill saying, to improve is to change. And we have really improved our treatment in myeloma. There is evidence to that. And to be perfect is to change often. And I'm very sure with the whole gamut of new drugs which are available and approved, we will change even more and provide even longer life to our multiple myeloma patients. With that, I'd like to thank you very much. If there are any questions, I'll be more than happy to answer. Thank you.
Thank you, Hemant sir, for your elucidated presentation. It was very nice. And I think we can allow 2 to 3 minutes for questions to the audience. If there are any questions, we can allow 2 minutes.
So, may I ask one question? If I have to use the 4 drugs combination daratumumab upfront, it is the VRD plus Dara is better, or it is the melphalan based Dara combination is better, or there is no difference?
So there has been no head-to-head comparison between these two regimes. There have been comparisons between the treatment with or without DARA. So basically, you need to assess if you have a very frail patient, then maybe DARA VMP might be a better combination as compared to the lenalidomide combination.
Sir, I have a question.
Yes, please go ahead.
As per sir, this recent AGH update by Dr. Rajkumar, they are advising bortezomib plus lenalidomide as maintenance post-transplant for high-risk patients. So they have added lenalidomide also after borte. So what is your practice, sir? You only bortezomib or combination of bot-len?
So actually, I am comfortable with lenalidomide maintenance because the tolerability is very, very good. With the 2-drug maintenance, either with bortezomib added or with transplant added, the toxicity is much more, and then you continue the treatment indefinitely. And maybe the MRD, once it becomes established in myeloma, will help us in deciding. Patients who are MRD positive may require a 2-drug maintenance, while patients who are MRD negative may require only a single drug maintenance or no maintenance also.
So Dr. Shyam has a question in chat box. What about bortezomib dexamethasone in transplant ineligible patients? Only 2-drug, bot dex.
So I think we did talk about that. We did discuss that. If you have a transplant ineligible patient who can afford daratumumab, a daratumumab containing regime is significantly better than a non-daratumumab containing regime. And if the patient is unable to procure the monoclonal antibody, then any 2-drug or 3-drug regime can be given, starting from VMP to RD to VRD.
With this now, I think there are no more questions. I would thank Professor Malhotra sir for his wonderful talk, and I would invite our next speaker, Dr. Pawan Kumar Singh, for his talk on sequencing of treatment in journey of CLL.
Thank you very much.
Pawan sir is presently at Artemis Hospital, Gurgaon. He is the head of hemato-oncology and BMT unit over here. So over to you, sir.
Yeah.
Thank you, Dr. Prakash Shekhawat and Dr. Naresh Somani for inviting me for this wonderful meeting which is going on. And the topic which I've been given is sequencing of treatment in journey of CLL. So if we see in recent years, there is a lot advances with availability of oral drugs, which is almost completely replacing the management of CLL, because previously it was chemoimmunotherapy requiring frequent admissions. So with oral drugs, there is a lot more advances, and many more drugs are also coming in CLL management of CLL. So normally, if we see the B cell developments, so BCR has very important role in the leukemogenesis, in the normal development of B cells, and also in the leukemogenesis there in the CLL. So this is in the bone marrow where it is antigen independent, and then in the peripheral blood during the maturation, antigen dependent maturation of the B cells, and which forms the mature B cells. So this is the CLL development model. So the hematopoietic stem cells, the oncogenic event probably occurring at this stage, which leads to the generation of CLL hematopoietic cell, and then antigen experience B cells. When after antigen exposure, it causes the unmutated CLL, and this is the mutated CLL. So which is probably has origin from the germinal center. So in the various B cell malignancies like mantle cell lymphoma, then marginal zone lymphoma, CLL, follicular lymphoma, then other one is the Waldenström macro, and there comes the role of BTK inhibitor in the treatment of these malignancies. So BCL receptor, BCR signaling. So it is a transmembrane receptor located on the B cell surface, and it is the key survival molecule for normal B cell development and also in the B cell malignancies. So in CLL, what we see, there is BCR signaling, which plays a key role in the disease pathogenesis and matches for antigens unique BC, and it triggers. So BCR stimulation occurs through signaling cascade and involving activation of various kinases like SYK, BTK, or PI3 kinase. So CLL, two separate diseases. It can be divided into two separated diseases: the pre-germinal center, whereas it is called as unmutated, and the post-germinal center, the mutated CLL ones. So if we see the survival of CLL according to the IGHV mutation and status, the mutated one has better prognosis in terms of survival, whether it is all patients or stage CLL. And if we see the PFS also, progression-free survival also is better in the management of CLL. And we know that as per the IWCLL criteria, there are specific indication when to start the treatment, and otherwise most of the CLL patients usually require follow-up, and when it's specifically indicated, the treatment is started. So these patients can be divided into four categories. One is the younger fit patients, so the newly diagnosed patients who are younger fit, or other one is the older patient with comorbidities. Then the separate entity which has different management is the CLL patient with 17p deletion. These this 17p abnormalities can be seen in newly diagnosed patients or can be acquired at the time of relapse also. Thereby, it is always recommended when the progression is there, the 17p, the FISH analysis to be done to look for the acquisition of these abnormalities, and then the relapse refractory CLL patient, which is managed in a different way. So as per NCCN guidelines, the newly diagnosed patient, the first frail patient with significant comorbidities, then more than 65-year patients and younger with significant comorbidity. Other group can be less than 65 without significant comorbidities. So first we'll take the younger fit patients with the non-17p deletion. So this is the example. 7 years back, he was diagnosed, and then on follow-up, when planning treatment, cytogenetic and molecular analysis was performed, and it showed normal karyotype, which was negative. IGHV mutation was mutated status, which implies that this patient has better prognosis. The pre-treatment evaluation which should be done in CLL patients is CBC, immunophenotyping, and assessment before treatment, the complete blood count. Whenever we embark on starting the treatment, the bone marrow aspirate should be done, aspirate and biopsy. Then additional tests like SPISH, IGHV mutation analysis, CT scan or MRI imaging studies based on the clinical need to look for the involvement of lymph nodes. So then IPI scoring also should be done to look for the, this is the CLL IPI scores, which helps in determining the prognosis of the disease. So what are the treatment options for these younger fit patients? FC, FCR, and then bendamustine, rituximab, ibrutinib, chlorambucil, obinutuzumab, ofatumumab. These are the first line treatment options for newly diagnosed patients. So if we see the CLL state, these trials, mostly from the Germany and this CLL8 German trial, it compared the FC versus FCR. So here also, if we see the PFS and overall survival, both were better for FCR regimen. The efficacy in older versus younger patients, even older patients are also had comparable overall response rate. And in younger patients also, the overall survival was also similar in both FC and FCR. The safety profile, if you see, the grade 3-4 adverse events were more common in FCR because of the more cytopenia and immunocompromised status. So risk of infection, bleeding complications, these were more in FCR. And then CLL trend trial, which compared the FCR versus BR. The primary endpoint was non-inferiority of BR versus FCR for PFS. And so here also the response rate was in FCR, it was better as compared to BR, and MRD negativity, again, it was more prominent in FCR group as compared to the BR. So here we see both the PFS was better in FCR but the overall survival at 36 months, it was almost similar in both FCR and BR group. So adverse events more common in FCR because and it was mainly neutropenia, anemia. So basically cytopenias, infections, risk of secondary malignancies. These are also more common in FCR regimen. So impact on MRD. This is important to note. The MRD negativity rate in FCR is quite significant, and it was almost 74% versus 62%. And follow-up, 53% were continued to be MRD negative who received FCR as compared to only 24 patients in the BR. The final analysis inferiority as compared to BR in terms of PFS and CR, and also MRD. And we with lower incidence of adverse events. So FCR is the standard of care in younger fit patients. BR may be considered in elderly fit patients. So there is another randomized trial which is going on by the CalGB group. CR versus FR is under, and it is two trial overall rates were similar in both the groups. So, but there were higher CR rates in FCR group. The other option is ofatumumab plus chlorambucil, and it has shown activity in previously untreated CLL patients, but long-term results of this regimen are unavailable. Then another is the BTK inhibitors, the ibrutinib. An initial trial of ibrutinib comparing FCR showed lower percentage of CR rates. So am I audible now?
Okay.
Yeah, I think my internet was some problem was there. Am I audible now?
Yeah.
Yeah. So this is for older patients, more than 65 years age, newly diagnosed patient, international randomized phase 3 trial comparing ibrutinib versus chlorambucil. The primary endpoint was PFS, secondary endpoint was overall survival, overall response rate, EFS, and physiological improvement. So in this study also, Resonate trial, there was superior efficacy with ibrutinib as compared to chlorambucil in terms of PFS, and the overall survival also was better in ibrutinib arm. The in CLL11 study, in which it is a randomized study comparing obinutuzumab plus chlorambucil and rituximab plus chlorambucil. The overall response rate was in the obinutuzumab plus chlorambucil arm. The overall response rate was better, almost 80% compared to 65% in the other two groups, and the PFS also was better in obinutuzumab chlorambucil versus rituximab plus chlorambucil. So subgroup analysis also, it favors the obinutuzumab combination. The most common adverse event were mainly it was infusional toxicity. So for older patients who with comorbidities, ibrutinib or obinutuzumab in combination with chlorambucil could be a better option. So now coming to the specific entity with the deletion 17p, patient with deletion 17p, they have similar response rate in patients who do not have these abnormalities, but they have shorter PFS and a pattern of continuous, they usually get relapses. So it is frequently associated with complex karyotype, and it is associated with inferior outcomes in treatment naive and also in relapse refractory CLL. In this Kaplan-Meier, we can see that 17p abnormalities, they have the worst prognosis. The Resonate trial, it was phase 3 ibrutinib versus chlorambucil in previously treated CLL patients. So there was crossover was allowed, and here we see in 17p deletion, the ibrutinib arm, when it was compared to ofatumumab, the ibrutinib had better survival as compared to the ofatumumab arm in 17p deletion patients. So for relapse refractory CLL patients, these are the options. So for rituximab not so FCR can also be given in relapse refractory. So this is key. So just quickly go over through about the BTK inhibitor for the treatment of CLL. So BTK, these are the covalent inhibitors, ibrutinib and acalabrutinib, both are available in our country. The zanubrutinib is approved, and it is the non-covalent inhibitors. These are still under trial, not yet approved. So ibrutinib, the response rates are better. So even in those patients who have, these are the first in those patients who have received purine analogs or bendamustine rituximab, they still had better responses with ibrutinib. So acalabrutinib, the advantage of acalabrutinib is that it has less off-target effects. So this is a highly selective BTK inhibitors. So because of which the toxicity is less in terms of bleeding or cardiac arrhythmias. Elevate TN trial comparing acalabrutinib plus obinutuzumab, acalabrutinib alone, and obinutuzumab chlorambucil. So here also the survival was better with combination acalabrutinib plus obinutuzumab in terms of PFS and overall survival also. Ascent trial comparing acalabrutinib with idelalisib plus rituximab or bendamustine. So here also with the currently available venetoclax also getting approved, the treatment is indicated as per the IWCLL criteria, and we have to see the TP53 mutation status. If the mutational status is negative and IGHV mutated, fit younger patients with GFR more than GFR normal, and the comorbidity index is less than 6. The options for these patients is FCR, ibrutinib, BTK inhibitors. The other combination could be obinutuzumab plus venetoclax or inhibitor plus obinutuzumab. For patient with IGHV mutated, those who are unfit or who have high comorbidity score, the options could be BR, BTK inhibitor plus minus obinutuzumab, or venetoclax plus obinutuzumab. For unmutated status, usually they are less responsive. So these upfront immunotherapy is not so effective. So here the options are BTK inhibitor plus minus obinutuzumab or venetoclax plus obinutuzumab. For patient with TP53 mutation or with deletion 17p, they are considered as high risk. So they should be upfront given BTK inhibitors plus minus obinutuzumab or venetoclax plus obinutuzumab. So the comorbidity is having or anticoagulant difficult to control hypertensive, the consider acalabrutinib or venetoclax before ibrutinib, or patients if they have bulky disease, they may because of the possible tumor lysis. For relapse refractory setting, the risk status, again, we have to see the TP53 or the 17p abnormalities. For fitness, for younger fit patients, the treatment of choice could be BTK inhibitor or venetoclax plus rituximab or PI3 kinase inhibitor can also be given for these patients. And it depends on the what treatment patient has received earlier. For patients with comorbidities or age more than 65 years, BTK inhibitor or venetoclax plus rituximab or PI3 combination plus rituximab. For patients with deletion 17p or 17p abnormalities, BTK inhibitor or venetoclax plus minus rituximab or PI3 kinase plus rituximab. So with this, I would like to end here. If any
Thank you, Pawan sir, for this nice presentation on CLL. You have taken us everything from chlorambucil to these BTK inhibitors and PI3K inhibitors. Now, I would like to invite the panelists and audience. If they are having questions, we can take a few questions for 2 minutes.
I think Shyam Agarwal sir has asked whether finite. So yes, sir, I would agree with you that the finite therapy for CLL management is because all the oral drugs which are available for the management of CLL, they have to be given indefinitely till progression.
Yeah.
Finite duration or bendamustine rituximab. FCR is the best option for younger fit patient because it has the advantage of getting even PFS is better, plus it has advantage of getting MRD negativity, and patient had sustained MRD negativity. So the advantage of chemoimmunotherapy is that it has finite duration of therapy.
Yes. Thank you, Pawan sir. As we are running short of time, so I would invite Shyam Agarwal sir. He is the Director Medical Oncology at Sri Gangaram Hospital, Delhi, for his talk on first-line treatment in DLBCL and high-grade B-cell lymphomas. What is new? What is first-line? So over to you, Shyam sir.
Yeah. So thank you very much, Chairperson, and thanks organizers for inviting me. Are my slides visible?
Yes, sir, visible in full.
All right. So thank you very much. So my job is to tell you the first-line treatment for high-grade lymphomas on the B-cell variety. So it's a little challenging task because very little is being done. But let's see what we can do, in current practice. So the slide moving. Yeah. So this is the characteristics of DLBCL in general. 60 to 70 years old male. They present in advanced stage nearly 50%, mostly with these symptoms. Extranodal involvement in 40 to 70%, bone marrow involvement in up to 20%, although upfront CNS involvement is lower. So I think these are challenging symptoms and signs and staging of DLBCL, which is extremely important. And then, of course, we are talking about various subtypes of non-Hodgkin's lymphoma. So initial slides are focused on DLBCL, which will then subsequently be followed by other subtypes of B-cell lymphomas. So this is the first line treatment options. As you are aware, R-CHOP has been very, very difficult to sort of defeat, although there are certain subtypes of B-cell lymphomas where dose-adjusted R-EPOCH regime is become quite popular and is recommended, which I'll just come to. And for patients with poor LVEF, we have to resort to non-adriamycin combinations, which are seen here, like CEPP or GCVP. So, this is an important consideration when you are looking at first-line treatment. For very frail patients, again, we have to, especially who are elderly, either a mini R-CHOP or R-GCVP or CEPP. So these are factors, which one has to keep in mind. And the role of lenalidomide maintenance is optional in first-line consolidation. So this is another important concept for patients who have high tumor burden, to look at tumor lysis syndrome prophylaxis. And we also tend to use rasburicase, especially in the first cycle, to prevent the occurrence of tumor lysis syndrome. So these are, a couple of slides to show the role of R-CHOP over CHOP, where you can see the median overall survival and PFS is better with rituximab, so which has become established now. And this is, you can see the event-free survival and overall survival. Again, R-CHOP, this is more than 20 years, data which has been there in 399. So 47% EFS as compared to 29%. So as I said in the beginning, R-CHOP is the standard of care for most DLBCL at this point in time. So now, how to improve upon R-CHOP? What can we do? Increase rituximab dose, add a novel agent, substitute a different antibody, different from CD20, add maintenance like lenalidomide, or intensify chemotherapy. So this is what people have tried, and I'll show you some data which is emerging now in few of these directions, like for example, addition of bortezomib or ixazomib, or giving Revlimid along with rituximab or bevacizumab. So these are some of the efforts which people have tried to make, and we did mention about dose-adjusted R-EPOCH, which has become standard in certain indications, has also stood the test of time now. I'll show you some data on autologous transplants following R-CHOP in certain subtypes of non-Hodgkin's lymphoma, and addition of drugs like enzastorin have not worked out. Lenalidomide is there. I'll show you some data, and substituting with a different antibody like ibinutuzumab again has failed, but I'll show you data on the new antibody. So these are, prognostic factors which might help us in taking a decision as to what treatment we should be starting with. Shall we just give R-CHOP, or we opt for another regimen based on clinical parameters? In like Hodgkin's, in DLBCL, the interim PET has perhaps not really come of age, but the use of molecular testing has become important, and there is quite a few understanding which I'll just share with you. So this is in patients without bulky disease, the data is actually on de-escalation. Instead of R-CHOP into 6, people have used R-CHOP 4 and then just follow it with 2 additional rituximab. And you see the overall survival in a large cohort, 295 almost each arm is similar. So this is basically a de-escalation study where in patients without bulky disease, you can get away with 4 R-CHOP and just 2 additional rituximab instead of 6 R-CHOP. This is to show that, almost 50% patients will be insufficient, and R-CHOP is only good for 50% of the patients, as you can see in the long run, if you look at the 8 to 10 year survival. And differences in clinical outcomes are driven by biologic heterogeneity. And that is what we know now, that GCB versus non-GCB, the results are inferior in the non-GCB variety. And we need to, have this testing available and figure out what to do for this subvariety, which is the non-GCB type. So this is again to show the data on ABC, which is the activated B cell, and the GCB, where R-CHOP does better for GCB and it is inferior for ABC. And if you look at these gene mutations, for example, a CD79B or MID88 or BCL6, etc. So it is much more in the ABC type than as compared to in the GCB type. So, this understanding of the molecular biology to identify the ABC versus GCB could help us in, giving more aggressive treatment to the ABC type so as to improve upon the efficacy. So there are, if you look at the, the ABC subtype and the non-ABC subtype in different regions, so nearly 40 to 60% patients will have either ABC or non-ABC type. So I think the focus is to identify the ABC type and strengthen your treatment there to get better outcomes. So I think these are various pathways. I'm not going to go into the details of this, which we are all aware. So I think I'll just skip this slide in the interest of time. So again, this is again the same slide which I showed you before, and I'll show you some data on some new trials. So, the cell of origin directed approaches have not so far resulted in the improvement over R-CHOP, and therefore we are still by and large stuck with R-CHOP at this point in time. But we are beginning to understand that GCB is a better outcome disease than as compared to ABC. So now coming to double hit and triple hit, which we can identify with MYC, BCL2 or BCL6 rearrangements, and maybe not expression. The high-grade B-cell lymphomas with MYC and BCL2, perhaps, which are very easy to diagnose in the lab these days, should be treated maybe differently. And this is to show the poor outcomes of double hits and double expressors in the large B-cell type. As you can see clearly, the double hit, which is the, the down here. So, again, the understanding that the double hit and the ABC types, they need, a different regimen than R-CHOP so as to get a better outcome. So I think I'll just want to show you the polatuzumab data, which is with the CD79B inhibitor. And so this got approval in the second line, or relapsed refractory patients who have been treated with 2 prior therapies. But we're focusing on the previously untreated DLBCLs. So here you have polatuzumab plus CHP plus vincristine versus R-CHOP with polatuzumab, and followed by rituximab in 7-8 cycle. So now you see the Pola R-CHP versus R-CHOP. The PFS, 2-year PFS is better. Hazard ratio is 0.73. EFS is better. And if you look at the, the forest plot, as we were mentioning, the ABC type here is doing much better. And if you look at certain other criteria, for example, a double hit, or it doesn't make a difference here. But I think the ABC type, this is, hypothesis generating. So what we are trying to say here is that the Polarix study, in which polatuzumab was combined with R-CHP, has shown a DFS benefit, unfortunately not the OS benefit. But then in the ABC subgroup, maybe when the data further comes in, the polatuzumab could be better. So I'll skip these these results. So, the analysis of PFS outcomes, as I have shown you, are superior, although, maybe small difference, but then the OS was not superior. But in certain subtypes, when you do further studies, it might stand up. So I think still R-CHOP can be improved upon, but we don't have confirmation or the solid data there. So this is now, as we know, the CAR T cells, they have again started coming in high-risk large B cell in the first line. And I think this is a phase 2 study, again showing the duration of response and the overall survival. The complete response rates are 78% with this CAR T cell, but I think these are early days and you need to do the randomized studies. So these are some other studies which I'll just show you. The acalabrutinib plus R-CHOP, tafasitamab plus R-CHOP, the other antibodies. I'll just show you a few studies here. So you can see the addition of lenalidomide, which was presented in JCO 2021, has shown that Revlimid, R2 and CHOP are better than R-CHOP in terms of OS probability also. And the p-value is just 0.05 here. So there is data to support using lenalidomide in addition to R-CHOP, and it can prolong survival. So this is the frontMIND tafasitamab study. So tafasitamab is nothing but a CD9 antibody. It's a lytic antibody. So which is when added to lenalidomide and R-CHOP here, compared to tafasitamab, placebo and R-CHOP. And I think the results are kind of preliminary here. But then I think this is the kind of study where we are waiting results from. So this is the acalabrutinib study when you are, using in combination with dose-adjusted EPOC or R-CHOP. So I think these are the kind of studies which people are trying to do now, and to sort of improve upon the efficacy of R-CHOP. So we don't have the data here, but so this is, to sum it up, people are wanting to combine polatuzumab with R-CHP. I showed you some, studies being done with tafasitamab, with R2 CHOP, and certain other antibodies. So I think we might sort of add on in the next 2 to 3 years with these new antibodies in terms of superiority over R-CHOP. So I think CAR T cells, I mentioned, is still ongoing. What about the other subtypes of aggressive B-cell lymphomas? So I think in the mantle cell lymphoma, R-CHOP is considered to be sort of inferior. So alternating R-CHOP and RDAP is one of the preferred regimens in practice, but I think one can opt for hyper-CVAD as well, and bendamustine-contained regimen can be used, which is a category 2B. So R-CHOP is considered inferior for mantle cell lymphoma, especially in the aggressive variety, but in the indolent type of mantle cell lymphoma, BR is preferred. So in aggressive lymphomas, there is a discussion on autologous stem cell transplant following the induction therapy. And if somebody is not suitable for transplant, or after transplant maintenance, rituximab can be used. So I mentioned about the high-grade B-cell lymphomas where the outcomes are inferior. So R-CHOP may be associated with suboptimal outcome, and therefore people resort to dose-adjusted R-EPOC regimen in a high-grade double hit or a triple hit lymphoma. So these is from the latest NCCN guidelines to be incorporated in our day-to-day practice. Burkitt's lymphoma, again, clearly CHOP or R-CHOP is not an adequate therapy. And if you have a young patient with high-risk disease, hyper-CVAD or Codox-M is supposed to be, used in the induction and in the first-line therapy. So I think dose-adjusted R-EPOC can be used in more than 60 years of age patients. So I think age, the risk of the disease, and the type of lymphoma are very important in first therapy to be selected. So what about HIV-related lymphomas, which we are seeing? For example, Burkitt's lymphoma, again, hyper-CVAD is recommended in the first-line therapy. For patients with DLBCL, our EPOC is first line, but R-CHOP is in the other recommended regimens. Plasmablastic lymphoma is another category in HIV where EPOC is the preferred regimen and CHOP is not preferred as first-line therapy. So you need to be aggressive in plasmablastic lymphoma. So I think your pathologist should be aware to give you these kind of diagnoses so as to select the right treatment, first-line treatment for your patient. Lymphoblastic lymphoma, if you have, I think the treatment is like ALL. So I think you refer to ALL like treatment in lymphoblastic lymphoma. I think this is my last slide. So there are certain special considerations in high-grade lymphoma which one should be keeping in mind. So I mentioned about rasburicase to prevent the tumor lysis syndrome, especially in patients who have Burkitt's lymphoma or high disease burden or high uric acid and compromised renal function. So very, very important to use rasburicase in the first-line therapy in particular. So I think this is another important take-home message from our side, that if somebody has a high disease burden, a pre-treatment, a low-dose first cycle should be given rather than giving aggressive therapy in the very first cycle, because patients won't tolerate. And then you can, in the first cycle, once the patient has recovered, well, then you can go all out in the second and subsequent cycles to give the full doses of the appropriate regimen. Another important thing to understand in CNS prophylaxis is patients who have extranodal disease, who have disease in the maxillary sinus or in the head and neck area, testicular lymphomas, and in HIV-related lymphomas. So I think you must routinely use CNS prophylaxis like intrathecal therapy. For mediastinal lymphoma primary, I think those are tested, R-EPOC is the standard regimen. And for primary CNS lymphoma, high-dose methotrexate-based regimen should be used. So I think this is what I would conclude here with in terms of the newer developments and the established first-line regimens for high-grade B-cell lymphomas, including DLBCL. Thank you very much for the invitation.
Thank you, Dr. Shyam Agrawal, sir, for this nice presentation. I have a question. I will stick to very limited thing. So do you still think there is a role of CNS prophylaxis?
For example, patients with testicular lymphoma, we are using, intermediate or high-dose methotrexate. But by and large, for DLBCL, for example, if somebody comes to us with, as I said, in head and neck area, maxillary sinus involvement, or we've got patients with liver involvement or lung involvement, I routinely only use intrathecal methotrexate. So you have the option of either consolidating subsequently with intermediate or high-dose methotrexate after completion of R-CHOP. But I think you have to look at the CNS prophylaxis in one way or the other in patients, especially who have high-dose, extranodal disease, patients who have, disease confined in the head and neck regions, or for that matter, in the spine where there is infiltration maybe into the meninges, and as I said, liver and lung involvement. So I think you cannot get away without CNS prophylaxis to my mind.
Okay. Thank you, sir. Thank you for this insight. Now I would invite Dr. Meet Kumar, who is a senior consultant at Fortis Hospital, Gurgaon, for his talk on early treatment with JAK inhibitors and survival goals in myelofibrosis. And the sponsor for this is Novartis for this session. So straight over to you, Dr. Meet, sir.
Thank you so much, Dr. Prakash. It's great to see you after a long time virtually.
Yes, sir, same here, same here.
Can the organizers please project the slides from their end?
Yes, Sweta, please do. Yes, please put in PPT mode.
Yeah, thank you so much. Yeah, so thank you so much. So at the beginning, that's a wonderful topic to debate on. So this is a topic for debate rather than sort of one-sided talk. The topic is early versus delayed ruxolitinib for patients with myelofibrosis. So I thank the Best Clinical Oncology Symposium 2022, the organizers and Novartis for having brought up this topic for discussion today in this wonderful evening meeting. And without wasting much time, I'll just go straight away to the discussion part, the talk itself. Next slide, please. So we know that in 2022, myelofibrosis has undergone seriously a sea change in terms of identification and prognostication of the myelofibrosis as a disease, and definitely in terms of treating it in 2022. The next slide, please. So this is now, there is a incorporation of a whole lot of new mutations that have come into clinical picture, and the next generation sequencing is probably someone is not doing in 2022. Probably he is not treating the disease properly. That is what can be understood from the West. Of course, we at Fortis also are not doing NGS for all the patients, but slowly and steadily, probably we are moving towards doing NGS for most of the patients, just like NGS has become a mandatory diagnostic step in most of the patients with acute myeloid leukemia. So these are some of the important mutations that are identified in patients with myelofibrosis. The TET2 mutation, A6L1 is a especially bad mutation to have in myelofibrosis, IDH1, 2, EZH2. Next slide, please. The DNMT3A, CBL, the NRAS, KRAS mutations, SF3B1 mutations, the TP53 mutations, all these fall under the category of something that is now stratified as, next slide, please, high molecular risk mutations. Similarly, on the karyotype, there are certain high risk or very high risk karyotypic cytogenetic abnormalities like deletion 7, deletion 17, all those I'll come to subsequently. So there are now stratification based on molecular and genetic data and cytogenetic data, wherein we can much more better prognosticate and stratify patients with myelofibrosis. Next slide, please. So that's the impact of identifying these mutations that has got a significant impact on the survival and the outcome of patients. And if we are able to identify the high-risk patients at the baseline and at the beginning of the treatment, maybe we will be justifiable in treating them optimally and with more aggressiveness for high-risk disease as compared to lower-risk diseases. Next slide, please. The next slide. So this is the prognostication IPSS, DIPSS that we have been using till 2016. But beyond that, maybe for the last 3 to 4 years or 5 years, the prognosis is slowly and continuously evolving and changing for good. Next slide. The MIP70 was identified in 2017, and subsequently for the next couple of years, these are the evolution to the recent one, that is GIPS, that is Global Integrated Prognostic Scoring System. And these prognostic scoring systems differ from the previous ones in the sense that more and more incorporation of the molecular mutations is taking place. Like if we talk about MIPSS 70 plus version 2.0, that has incorporated the very high risk karyotype as well as the high molecular risk mutation, high molecular risk mutations, including the CALR absence, as a prognostic parameter for identifying the very high risk myelofibrosis. So how they stratify them, that can be seen in the table below. So as per MIPSS 70 plus version 2, they can be stratified as per as very low risk, intermediate risk, high risk, and very high risk. So previously till DIPSS, probably it was low, intermediate, and high, or low, intermediate 1, intermediate 2, and high. But now slowly and steadily we are moving forward in sub-stratifying these categories into much more refined manner. Next slide, please. This definitely has an impact on the treatment as well. The very high risk disease and the high risk disease to be treated with a bone marrow transplant where the patient is eligible, or a novel agent based therapy if not eligible. The very low risk disease may be only monitored based on observation. Intermediate and low risk is the treatment, is the area where a lot of science and intellect goes in terms of treating these patients. Depending on the symptomatology, if the patient is anemic, maybe you can try with androgens, danazol, thalidomide, steroids. If the patient has splenomegaly, we all know from ages, ruxolitinib is the drug to go for, and we have all seen successes with the use of Jakavi for unrelenting splenomegaly in patients with myelofibrosis. For constitutional symptoms, COMFORT 2 trials initially only had shown in 2012 that the health-related quality of indices definitely show an improvement with the use of ruxolitinib, much more better than use of hydroxyurea or splenectomy. For localized pain or symptom relief, definitely localized field radiotherapy may be useful. Next slide, please. The GIPSS scoring system again can be stratified in the base on the same manner, and the treatment lines are essentially the same. The next slide, please. These are the new trials that we have seen in the last couple of years, for the last 5 years, and that is what has changed the treatment outcomes and parameters and the way we treat myelofibrosis in 2022. The important trials are COMFORT 2, JUMP, and REALIZE. Next slide, please. This is the graph that we have seen for ages now, 2012, the publication on COMFORT 2 trial that was made, and we all know that the success of ruxolitinib as compared to best available therapy for splenic response has been noticed for ages. Next slide. If we talk about the second curve that has shown the improvement in fatigue, pain, dyspnea, insomnia, appetite loss, all those in constitutional symptoms do show a significant benefit in terms of improvement with the utility, with the use of ruxolitinib for the treatment of this kind of symptoms. Next slide. So this is an interesting paper that was published in 2017 that identified, other than the MPN-10, the symptomatology, these are also the symptoms that can be ascribable to myelofibrosis patients: difficulty in sleeping, numbness, tingling in the hands, feet, dizziness, vertigo, pruritus. All these symptoms are ascribable to a patient of myelofibrosis, to the disease itself, rather than these things being ascribable to drug side effects or other toxicity. The next slide, please. This is a JUMP trial. That's an important trial that has changed the way we look and treat myelofibrosis now. This is the first data that was published in 2019, and that 2020, sorry, that showed that the utility of ruxolitinib is more so in when it is used as early in the treatment paradigm or treatment utility of myelofibrosis, rather than using it in a delayed manner. So what this study did was, the next slide, please. So the identification or the inclusion criteria were the diagnosis of PMF, post-PVMF, post-ETMF, high risk, intermediate 2 risk, intermediate 1 risk as per DIPSS, and a palpable spleen more than 5 centimeters. And these patients were randomized to receive different dosages of ruxolitinib based on the platelet counts. Next slide, please. I think we can go to the next slide, another slide. So the predictors of spleen response in all this category of patients, if you see in the pointers in red, is lower IPSS score. The patients who had a lower IPSS score and had a splenomegaly, and when these patients were treated with ruxolitinib, the chances of responses in these patients were quite high as compared to when it was used for higher risk IPSS patients. Similarly, maintenance of dose at week 12. So those patients who initiated 20 BD and had a maintained dose till week 12 of similar dose, those patients had a higher chance of responses, coupled with a lower IPSS score, was a significantly better predictor for response. Next slide, please. Similarly, those patients who had a poorer health-led quality of life indices, in those patients, similarly, the maintenance of dose of ruxolitinib and early utility of ruxolitinib had a better impact on the outcomes. Next slide, please. Another one. Next slide. Yes. So this is what the first time it was shown that ruxolitinib is a drug that has got an impact on the outcome in terms of overall survival. So overall survival was improved in patients who were treated with ruxolitinib as compared to those who were not treated. And the outcomes were definitely better in the lower risk and intermediate 1 risk MF as compared to intermediate 2 and high risk myelofibrosis. Next slide, please. So the conclusion that this JUMP study showed us was that it identified that lower IPSS was a significant factor for predicting higher spleen response rates. And these findings also demonstrated that treating patients with ruxolitinib earlier in the disease course, using ruxolitinib as a first-line therapy, and maintaining ruxolitinib treatment at a higher dose, all led to higher splenic responses. So that is what was the important study outcome with JUMP study. Next slide, please. So what is meant by early? So what do you mean by early? We want to use it early, but how early is early? So based on the MPN-10 scoring, anyone who's got a score of 5 or more can be exposed or treated with ruxolitinib, and we can expect the good or better responses with the as just like the higher like the lower IPSS risk score patients. Next slide, please. That's another important study. That's a realized study that showed us the way of utilizing ruxolitinib in a staggered dosing. So that means you start initially with a lower dose for patients who have got an anemia or who have got a lower platelet counts. And in those patients, if the patients tolerate and slowly there is a response seen, then slowly you can jack up the dose to the conventional dose. So the eligibility criteria was spleen more than 5, age more than 18, hemoglobin was less than 10. So patient had to have a hemoglobin less than 10, good performance status, and the diagnosis of myelofibrosis. Next slide. So in step 1, they were all started at 10 BD, and slowly when the patient started showing response, the doses were slowly jacked up in phase 2 to 10 to 20 BD, that is a full dose. Next slide. I think I can skip 2 more slides in the interest of time. Another one. Yes, so this is the one. So like the patients who had started with transfusion dependency had got a poorer response as compared to those patients who were not transfusion dependent. And similarly, those patients who had got a higher or a larger spleen had got a lesser response as compared to those who had a smaller spleen. The next slide, please. So the conclusion of this realized study was those patients who had anemia and required JAK inhibitor, the choice of initial ruxolitinib dose could be based on the degree of need to achieve the rapid spleen reduction. In case of moderate to marked and but not massive splenomegaly, possibility of adopting a staggered two-step dosing policy may be utilized. And finally, in anemic patients with constitutional symptoms but without significant splenomegaly, selection of lower starting dose may be useful and rational. So this is what the study taught us, that staggered dosing in patients who have a pre-existing anemia, using a staggered dose, lower dose initially and slowly jacking up to the full dose, may achieve us both the perspectives of improving hemoglobin as well as achieving a splenic response over time. Next slide. Next slide. So what are the recommendations of bone marrow transplant in patients with primary myelofibrosis? Indications include intermediate 1, intermediate 2 and higher disease, patients who would be less than 65 years of age and who are refractory and transfusion dependent with a blast count of more than 2% in peripheral blood and an adverse cytogenetic, patients who have got triple negative or an ASXL positive myelofibrosis. So that's an important thing. ASXL1 alone has got a very poor prognostic feature for patients with myelofibrosis, and the use of newer classifications of molecular based classifications that incorporate the patients into higher risk myelofibrosis are an indication. Next slide. So both the conditioning regimens, we recently have a patient who has been treated with RIC regimen, and those patients are typically have got a prolonged time to engraftment, but at the same time, the outcomes are better as compared to chemotherapy or novel agent therapy based alone in the long term, because that's the only modality that can have a curative treatment intent for these patients with myelofibrosis. Next slide, please. Next slide. Next slide. So this is an interesting observation. So we know that close to half of the patients can have a tendency to discontinue ruxolitinib at different time points. So what are the predictors for treatment discontinuation, ruxolitinib discontinuation? So again, what is interesting here to note is a higher DIPSS score or intermediate 2 risk DIPSS score has got a potential that these patients might discontinue the treatment early, or the patients who are transfusion dependent to begin with, or who have got a lower platelet counts to begin with. So these are the patients who have got a higher chances that they might treatment discontinue over time. So again, next slide, please. So of course, those patients who discontinue ruxolitinib have got a very poor outcomes. So as far as possible, the treatment continuation may have a positive impact, but for whatever the reason treatment discontinuation is achieved, that has got a negative impact on the outcomes. Next slide, please. So it's interesting that higher DIPSS, lower platelet count, unfavorable karyotype and transfusion dependence have got a higher chance of probability of drug discontinuation. And the outcome of patients who discontinue ruxolitinib remains dismal. So that again justifies that patients who are able to start ruxolitinib early in the disease course, they might be better tolerating the ruxolitinib, as well as the outcomes in those patients may be better because they possibly would be able to receive ruxolitinib for prolonged duration. Next slide. So I'll come to probably the end, last 1 or 2 slides, that early ruxolitinib proves to be more beneficial in terms of lesser adverse effects. So that is what the topic was given to me, early versus delayed ruxolitinib. And probably we can say that based on the available data, at least, personally speaking, I'm not using early ruxolitinib for all the patients. That is a case-by-case discussion. But yes, as per the data says, early ruxolitinib proves to be more beneficial in terms of lesser adverse effects, better spleen size reduction responses, and decreased infectious complications and decreased discontinuations. But of course, we need to be aware about some of the side effects of treatment discontinuation with ruxolitinib. That includes, next slide please, ruxolitinib withdrawal syndrome, and there is some limited risk of fatal opportunistic infections that can be associated with ruxolitinib. With this, I come to an end, and thank you, and I hand back the proceedings to the organizers back for further proceedings.
Thank you, Meet sir. Thank you for this presentation. And if there are any questions from the panelists or audience, I would like to take 2 questions. So, sir, I have a question. Do you check for a hepatitis B core antibody in cases of ruxolitinib?
So routinely, I'm not doing. The recommendation definitely suggests that's a soft indicator to check for the various viral markers. So not antibodies, but I screen for the viral serology at baseline before starting all the novel agents. That is there, but specifically I don't check for the HPV antibody titers or something like that.
Okay, okay. Thank you, sir. So now I would invite Dr. Dubey for his presentation on CML, hit hard and hit early in CML. He is a medical oncologist at Santi Mukund Hospital, New Delhi. Over to you, Dr. Dubey. You can put it in slides or more. Yes, it is there.
I hope my slides are visible and I am audible.
Yes, yes, both.
Yeah. Good evening, everyone. Thanks to organizers and Novartis for giving me this opportunity to speak on this particular topic. So I'll start my presentation with a case history, which is of a 30-year-old recently married female who has come with the complaints of left hypochondrial pain and increasing fatigue that couldn't allow her to keep up with her hectic lifestyles. And the baseline evaluation revealed mild anemia and moderate to massive splenomegaly. There's grade 2 hypertension also present, though patient is not on any medication, and dyslipidemia. A routine blood investigation also revealed increased WBC count 87,000 per cubic millimeter with left shift myelocyte bulge and the occasional blast amounting for around 5%. As I've already said, that moderate to massive splenomegaly, small splenic infarct, mild anemia, and normal platelets. Bone marrow as well as cytogenetic analysis revealed the diagnosis of chronic phase chronic myeloid leukemia with the so-called risk 1.7, the most commonly used risk stratification score. So this patient is now labeled as chronic myeloid leukemia in chronic phase with high so-called risk. So what are the treatment goals in patient with high risk or high so-called risk CML-CP? So first is to achieve an early molecular response. That is the first molecular goal, so as because it is associated with the various trials have actually predicted this goal to be associated with very good progression-free survival and overall survival. Secondly, to prevent the progression of this chronic phase to accelerated phase of the blast crisis owing to poor outcomes in these particular phases. And thirdly, achieving these things using a drug which is having a very good tolerability, which maintains the quality of life and increasing the survival. Yes, if we are able to achieve these molecular milestones, we'll be able to achieve the survival and also can give a trial of a treatment-free remission, provided patient actually achieves a durable deep molecular response. And thus, and patient who are being given trial for this treatment-free remission, 50% of the patient will not require TKI in a limited follow-up. So that might result in a cure also in a small setting of the patient. So these are the established treatment goals in patient with CML. And early molecular response is the first molecular milestone, what we actually aim for. Then is major molecular response, that is 3 log reduction in BCR-ABL1 transcripts. And achieving these responses is very significantly higher with a second generation TKI as compared with imatinib. And also the frequency of progression to accelerated phase and the blast crisis is lower, significantly lower with the second generation TKI as compared to imatinib. Though the overall survival rates are similar with the both first and second generation TKIs, but actually it requires a longer follow-up so as to actually conclude on this particular outcome. So these are the key predictors in chronic myeloid leukemia. The frequency of achieving these complete cytogenetic response, progression-free survival, and overall survival in high-risk patient is significantly lower as compared to the low-risk patient. As you can see in these graphs, patient with the low risk, there's a complete cytogenetic response. The frequency is 88%, whereas in high risk it is 66%, and same overall survival at 5 years is 98% for low risk and 79% with high risk, which is significantly different. So in this particular patient, a young CML chronic phase with high SOCA risk, what will be the drug of treatment of choice? So naturally, it will be, for me, it will be a second generation TKI, nilotinib, because with the longer and much more confidence with this drug, at least for me, because second generation TKIs are associated with reduced progression to accelerated phase in the blast crisis, and also the molecular milestones achievement is significantly higher and earlier with the second generation TKI. So which subset of the patient we actually practice or we prefer the first line therapy with the second generation TKI? And it has been seen that the health related quality of life in patients with a chronic myeloid leukemia receiving the first line therapy with nilotinib is significantly better, and the overall compliance rate with the health related quality of life was seen to be 95.4%, and the rate of overall compliance was 91%. There was statistically significant improvement in physical functioning, role functioning, and fatigue, and the clinically meaningful improvement were also found already 3 months after the treatment starts. So for the most of the patients, health-related quality of life improvements with nilotinib occurred during the early phase of the therapy and were maintained over the time. So as we know that early molecular response is the first thing, that is 1 log reduction in BCR-ABL1 transcript, and it is associated with the improved progression-free survival and overall survival, and failure to achieve this at 3 months is considered to be the failure. So as you can see in this particular slide set, that irrespective of the risk stratification, whether it is low risk, intermediate, or high risk, patients started on a second generation TKI, that nilotinib 300 mg BD, achieves this particular molecular milestones significantly at a higher chance than a first generation TKI. And you can see in a higher risk patient, this achievement with the second generation TKI, that in nilotinib, is almost doubled. So this is the pooled landmark analysis of the patient with high SOCA risk scores, and these molecular milestones, as you can see, that the high molecular milestones are achievement is actually higher with the patients who are actually started on a second generation TKI, and this NSTENT study at 5 years, the deep molecular response by SOCA risk. So you can see that patients who are started on nilotinib, irrespective of the dosage, whether 300 or 400 mg BD, as compared to the imatinib, patients who are started on nilotinib actually achieved deep molecular responses at a higher frequency as compared to those who have started on imatinib, irrespective of the risk stratification, whether it is low risk, intermediate, or high risk. So this patient, because owing to a high risk young CML CP patient, he was started on 100 milligram dasatinib upfront. However, the patient actually developed grade 3 pleural effusion. That serositis is one of the common adverse event with the dasatinib, along with the cytopenias, which actually did not resolve with the dose reduction. So patient requested a change of therapy, fearing the development of pleural effusion again. So when we are actually trying to achieve these molecular milestones to give a near normal life expectancy to the patient, we should also see that the patient is able to tolerate the drug, and we are able to give, or we are able to preserve the quality of life in these patients. So there's one very interesting comorbidity index, that is Charlson Comorbidity Index, CCI, which is actually based on multiple factors, that is cardiovascular, cerebrovascular, hepatic, respiratory, and renal, as well as presence or absence of any other tumors and the diseases like AIDS, based on which patients are being labeled to have either CCI less than or equal to 2 or more than 2, and it was being seen that the patient who actually scored more than 3 points after calculating the number of factors what patient is having, the patient who actually scored more than 3 points had significantly shorter survival after diagnosis than those who scored less than 2 points. So as we know that there are higher chances of cardiovascular or the cerebrovascular events with a second generation TKI. So generally, cardiovascular evaluation should be done before initiating a TKI. This is the forest plot, which actually clearly indicate that yes, the meta-analysis of at least 10 clinical trials says that the risk of vascular occlusive events were higher with all second generation TKI as compared to the first generation TKI. So, but it was also seen that these adverse event actually occur in patients who have actually higher risk Framingham category, that is more than or equal to 20 points. So coronary heart disease risk at 10 years in the person can be calculated with this Framingham risk score. Lows are the patient with less than 10 points, high with more than or equal to 20 points, and intermediate between 10 to 20 points. So this patient's Framingham score was 6. And also there were, after the assiduous analysis of the study, it was been shown that yes, with the second generation TKI, though there were increased incidence of this cardiovascular event, but they were much more in the patient with high Framingham risk category. So this, our patient actually becomes the low Framingham score. So 30-year-old female, because of dyslipidemia and hypertension, the score becomes 6. So cross-trial comparison of the CV risk is difficult due to different endpoints, and they are being defined and reported differently in each study. Thus, cardiovascular events frequencies cannot be actually directly compared across the studies. And also it cannot be said that only the patients who are started on a second generation TKI are supposed to get these cardiovascular adverse events. So cardiovascular events based on Framingham CV risk score at baseline, you can see the patient who were actually having low Framingham score, the incidence of or the risk of CV with the second and the first generation TKIs were actually comparable. So the patient who actually had higher risk of this CV or cardiovascular event were those with the higher Framingham risk scores. So our patient, because she was a case of low Framingham risk score, so she was changed or switched to nilotinib 300 mg BD as she was not tolerating dasatinib. So at 3 months, patient was able to achieve the early molecular response. Quantitative BCR-ABL1 was less than 10%. Patient continues with nilotinib. So how frequently would you like to monitor this patient? There are multiple monitoring schedule in the patient with the CML which are acceptable. Yes, one must actually monitor these patients every 1 to 2 weeks till they achieve hematological response. And then later, every 3 months, till patient achieves major molecular response. And after patient achieves major molecular response, then we can actually reduce the frequency of quantitative BCR-ABL1 to every 6 months. And it is being seen, retrospective studies, that patients who have actually higher frequency of monitoring, the progression rate to accelerated phase or the blast crisis are significantly lower. So patient continues on nilotinib 300 mg BD, and BCR-ABL1 was less than 0.01% at 2 years. So patient actually achieved deep molecular response under regular follow-up. Adherence to the treatment is also good. So is this patient actually a candidate to consider for treatment-free remission? So first of all, we just see that the time to first major molecular response of the deep molecular response are also significantly shorter with a second generation, that is nilotinib. As you can see that with the nilotinib, the time is median 8.4 months as compared to imatinib 14.16 months. 14.16 months to achieve major molecular response, and to achieve a deep molecular response, it is 37 months with the nilotinib as compared to 41 months with dasatinib. And also patients after 5 years of treatment, between 5 to 10 years, actually additional patient achieve deep molecular response with the nilotinib, as it is being seen in NS10 study. You can see this is deep molecular response at 5 years. There was 53.5, and at 10 years there was 61.2. So there were extra patients which actually been added to this particular deep molecular response category, which can be an eligible criteria for considering the treatment-free remission trial in these patients. So whom to consider stop TKI or give a trial of treatment-free remission. The things which are in green with the non-high SOCAL risk score and in chronic phase and optimal response to TKI and deep molecular response achieved, and the duration of deep molecular response should be 2 or more than 2 years. Yeah, there should be an intensive monitoring after stopping the TKI for initially, later which can be reduced in the frequency. So coming to the conclusion that high SOCAL risk chronic myeloid leukemia chronic phase patients have higher risk of progression to accelerated phase of the blast crisis in first 5 years. And the choice of the treatment depends upon the patient goals. And the second generation of TKI are actually more efficacious in achieving the molecular responses and also achieving these molecular response with rapidity. But whenever a second generation TKI is to be considered, patients' comorbidity should be considered, and we have to actually choose a treatment or a drug which is actually having a very good tolerability profile so as to give or so as to preserve the quality of life. Cardiovascular risk factor is not an absolute contraindication to the nilotinib, and the decision should be based on Framingham score. We can actually give the patients who are having low Framingham score, and monitoring should be frequent, at least initially, till patient actually achieve major molecular response, and it improves the compliance also and early identification of disease progression. Thank you.
Thank you, Dr. Dubey, for this talk. It was a nice talk on CML with all the latest updates. I'd like to ask one question to you and Malhotra sir also. So don't you use ELTS score nowadays, or still sticking with the SOCAL score?
Sir, I use SOCAL only, sir. ELTS.
Okay, sir.
We don't use in RHS.
Malhotra sir. Okay, Dr. Dubey, what you were saying?
Yes, sir. Like, I just wanted to know your opinion on this. Do you use ELTS more or SOCAL? SOCAL because it has been more frequently and since more longer time it has been used. So we continue with this.
Yes. No, for last 1 year, I have changed to ELTS personally. That's what I'm asking.
And what's the difference you found, like, if you are able to, like, tell?
Anyway, it was a wonderful talk by you and by all the speakers, including Malhotra sir for this multiple myeloma talk, then Dr. Shyam Agarwal and Singh sir and Meet sir and you all have highlighted nicely, mainly on the B-cell malignancies and MPNs also. And I would like to give my back to the organizers, to the team for conclusion.
Thank you so much, sir, for the well-organized session coordination. I think we can close the meeting now with your permission.
Yes, we can close. Thank you. Good night, all.
Thank you, sir.